Again, that is it, sure. We are together again. The spring of love. Something good is going to happen. Something good is in store. 60. This is definitely it. I'm only seeing about 7 persons online. There's Alex, there's April, there's Cheryl.
Afternoon, man.
There is Judy. There is Vanetta. Where are your colleagues?
Checking on them.
Sir? Okay. All right, we are drawing down to the close of our health promotion one. Or 2 classes we have leave or 1. When I can sit back, relax, and just listen to you guys talking to me. I'm looking forward to it. Can I tell you? All right, we are going to be looking at renewal of health promotion this afternoon. And these are the objectives that I do hope we'll be able to achieve at the end of this discussion, that you should be able to outline what is renewal of health promotion and justify its, that should not be it, that should have been its importance in improving population health. You also should be able to describe the 4 strategic plans that should be used in the renewal of health promotion, as well as plan ways in which the renewed health promotion strategies may be utilized to enhance health in specific settings. So when we talk about the renewal of health promotion, the first thing that we want to have an understanding of is what is renewal. And renewal is the act or process of making changes to something in order to improve it so that it becomes more successful. So whatever we have as something working, we want to improve it. So you talk about remove renewal in some like in the business sector, they say that they are re-engineering and they are whole part of things, and sometimes in that process you find that they lay people off because they are restructuring and they are re-engineering. But in health promotion, we want to look at ways in which we can refine what we already have in working with the people so that it can be better utilized and better serve the purposes for which it is designed. There are different approaches such as the political, the social, and the technological that are really needed as we try to improve health and to level the playing field by reducing inequities I would have spoken several times about the whole business of inequity. The fact that despite all of the efforts that we have put into it, we have not yet reached that place where the playing field is level for the persons that we seek to serve. The question can be asked then, is health promotion aging? Why is there a need for a renewal? Now, it has been known for over a century that health is influenced by social and political factors, and hence the health system by itself would not be able to improve health. So there are changes that needs to be made, but those will have to go through Parliament. It has to be channeled through the political system for it to become laws or to be signed up on as policy. And so we cannot do it without the political persons on board. The term health promotion would have been around from 1945. That is many, many years ago, like about 83, 82 years ago. It has been around for a long, long time and was coined by this man. His name is Henry Sigerist, and he was a medical historian. And this is coming from the gentleman by the name of Kumar, 2012, who actually helped us understanding that health promotion is not something that is new, but it has been around for quite a long time. It is also, when we look at a landscape for health promotion and whether or not it is really changing, we have to recognize the fact that it's a dynamic movement for health promotion, and this dynamic movement is taking place across the region of the Americas. And it is not just across the region of the Americas, it's a global thing that is happening. This whole trust into trying to be healthy is a part of what health promotion is all about. It is really a global phenomenon. Ministries of health in over 30 countries and territories across this region, and here we're talking about the Caribbean region, have convened meetings, and they have had meetings with intersectoral actors. They have had community members in engagement, and they have also engaged civil society. And they are doing this because they really want to situate health within the context of the Sustainable Development Goals. And it's the development of those development agendas that they would have had, and for Jamaica, that development agenda is the 2030 agenda. And in a previous presentation, we would have looked at a different titles given to these development agenda for different countries across the Caribbean. So, do we need to make a change at this time? There has been several international conferences since then. And we talk about the Alma Ata Declaration, we talk about the Ottawa Charter, the Jakarta Declaration, and we would have delved a lot in these when we had looked at different charters when we were going through the Ottawa Charter and what transpired since its inception. And given all the changes in epidemiology, demography, and globalization, the time is ripe for this renewal of health promotion, because we can't say stagnant, but we have to look at a changing environment, and whatever strategies we are going to bring to the table must be in keeping with the changing global environment that we are actually in. And so there was a call for health, and there was a search for a better. Why is this thing, the font has changed? The search was on for a better health and well-being, as well as increased health equity. And the Ottawa Charter for Health Promotion, which was developed in 1986, as you can recall, outlines the main strategies and pillars of the health promotion. However, there was a need, and there still is a need, for a reinvigoration and a renewal of health promotion as we go forward. And that reflects, and whatever we are going to be doing must reflect contemporary realities of the region in any efforts to achieve better health equity and to contribute to the achievement of the Sustainable Development Goals. So it means that we can't have this one paintbrush that we used to paint everything, but we continuously have to be refining and redefining what we do. So for example, when we had like the COVID outbreak, I would have had several different presentations, but it was all about COVID-19. Why? Because there are different target populations that you have to engage. So the way I would do a presentation to engage students in a primary school, I could not use that same presentation for a group of healthcare workers. I could not use that same presentation for an adult community audience. So we have to, I usually have to remake the presentation to fit the specific audience that I am going into. So we'd have had a whole lot about health promotion, but then we need to do some renewal that we can keep pace with changing environment around us. So what then really is the renewal of health promotion? And this is the process of reaffirming the fundamental principles that were articulated in the Ottawa Charter while reinterpreting them for contemporary issues. And we look at issues such as globalization and digitalization. And you will admit that globalization has brought the world into what is called a global village. So gone are the days when it was them over foreign and we over here. Because of the ease of travel and access, it takes just one, not even a full day, for disease to move from one region to another. If we go back and we look at the, it wasn't SARS, it was the one that came after SARS. That started in that when there was a conference in China. And by the time the conference was over, that germ was globe-trotting. So persons who returned to their country from that particular conference, once they enter the hospital for, it was a respiratory syndrome. It was a respiratory infection. I can't remember the exact name. But once they returned home and they reached the hospital, they were under total shutdown. So you find that the rate at which it was spreading, those who were in the hospital, once they enter, they couldn't go home to their family. Nobody was allowed in. It was a chaotic time. So we have had those issues, just that particular one did not do the global trotting the way COVID-19 did that global trotting. So we have, because of globalization and the ease at which people can travel, that germ can move from one country to another within a few hours and can trigger a whole tsunami in other countries. Digitalization, we see where that increasingly there is being stressed on us going digitalized, this digitalized economy. And so the government is pushing it, and they are pushing it from all different angles. But I say there is nothing wrong in digitizing certain things, but the extent to which they want to take it. It was just this morning where I was reading an article on the internet where I think it is Sweden, that they are now injecting a little chip into the hand, and that chip have everything. They don't even have to carry phones. So I don't know, only technology work, maybe it has a, what do you call that attachment to it? It's not Wi-Fi.
It's probably a RFID thing, similar to what it is they use to tap your credit card or debit card.
I'm not hearing you clearly, Daniel.
Oh, sorry. I'm saying that it's probably an RFID thing where it is that you can tap your credit card or debit card, a similar chip.
Exactly. That's the kind that they have to just say, no, it's for convenience. But I say to persons that it's slavery of a different kind.
It's
because when they have total control over all of those things, all they need to do is to press one button and everything shut down, and you're not able to access anything at all. So I hear people cursing out that those who have concern that they are backward and they don't want to move forward. And I'm saying move forward into what? We are slowly losing autonomy over things that we had control over. One person, press one button, and everything shut down. And we don't realize what we are gravitating towards. All we can think about is the convenience. I don't have to walk with cash. I don't have to walk with any handbag. I don't have to walk with this. I just sweep mine across a little pad, and everything that I want is supposed to be there, and it can happen. And so while we do embrace development, we need to stop and think carefully about what is it that we are embracing. But I promise you that based on this push for digitalization, that we are moving from the slavery that we would have abolished into a different form of slavery. Because this time, all the government what I need to do is to say to us, jump. And we need to just ask jump how high. Because if we start to protest and go there and block the road and all, they just press one button and nobody have any access to anything. So we are going to be controlled even worse than how we were in slavery. But it is all a part and parcel of development and moving with the current technology. So maybe I am old school and you don't agree with me, but that's where that's the lens that I am looking at what is happening from. So I'm not saying no to the development and the digitization of something, but for me, there is something that should not go on that platform. So that's my point of view on it. We also have to look at social and economic inequalities and the fact that we have been having increase in the non-communicable diseases. We know the whole issue of climate change, and we can look at what happened with Hurricane Melissa, and they are actually causing out the government, that the government has something to do with the hurricane and the force of the hurricane. So a whole lot of things, yeah, it's true. A lot of things are going on out there, and we do know that they do have technology, and technology is well advanced beyond our capacity and understanding, because we are not, we don't have access to the extent to which technology has advanced. So the question now is, what is truth in what is going on out there? What you do picnic with the donut in the class, Jesus. So I am laughing because your colleagues inside the classroom are really having a whale of a time with junk food. And we're talking about health promotion and healthy eating, right? So talking about emerging pandemics. And we could have seen this, we have seen what happened with COVID-19 and the pushback to the vaccine, because persons were not embracing the technology and the quick ease with which they were able to come up with a vaccine. I mean, things drop today and tomorrow vaccine is available. Questions were being asked, a lot of questions. They call it conspiracy theory. But if you're a Jamaican, there's an old saying, if you don't go so, in there go so. Mm-hmm. Yes, I will hear our grandparents with those things. And also impacting us was the rapid demographic and cultural shifts. I would have seen where we have moved from the demographic transition, where we moved from a young population and we are going into aging population. And with young people like yourself declaring war on birth rate, then you know that we are really going to continue to age and age for a while, and one wonders what is going to be happening to the population then. But then at my age, I may not be around to see what transpired at that particular point in time. So I just ask you that you keep your eyes open for what is going to be happening as you move forward and go ahead. Also, one of the things that we have to look at when we think about the whole business of the renewal of health promotion is that it was officially endorsed in several World Health Organization and PAO conferences. I would have looked at some of those last week or earlier this week. You have the Bangkok Charter, which was 2005. I spoke about the reorientation of health promotion towards globalization, equity, and partnership. The Nairobi one was a call for action, and they were asking for a stronger political commitment and evaluation frameworks. In Helsinki in 2013, they look at the whole business of health in all policies. And in Shanghai, China, they had a declaration in 2016 that linked health promotion to the Sustainable Development Goals. And in 2023, there was a reflection, a Caribbean reflection, spearheaded by the Pan American Health Organization. And in this particular meeting, they were reaffirming the Caribbean Charter that would have been developed before. And so there was also a call for renewal and the repositioning of health promotion as part of the regional agenda. And so there is indeed a need for revamping or improvement of our health promotion through the use of the social, the political as well as the technical initiatives to address the social determinants of health. And so we're really aiming in this whole renewal business to improve health and to reduce health inequities. How do we do that? We need to reinvigorate, we need to redefine, and we need to adopt health promotion principles and practices as we respond to the new health challenges and as different conditions come on the agenda. It is going to require different challenges to handle them. And going back to COVID-19, that's the most recent one we'd have had, and it really took a lot for us to really manage that particular one. And initially we were not managing. And it took a while for us to manage. I hope that there are lessons that would have been learned. And because going forward, there are going to be others. There are going to be others. This whole business of free emerging diseases is really going to be happening. Some of them, like COVID-19, you have no idea where they came from. I mean, on the ground, people are saying have a lot of theories as to its origin, and we are not getting anything confirmatory to refute or substantiate some of the arguments that have been put forward, and sometimes the wrong target get blamed for what we are seeing. So when we go out to eat, we are actually hitting at the wrong place because that's not where the origin might necessarily be.
Everything making a lot
We also have to look at
nowadays.
social. Go ahead, Daniel.
I said everything making a lab nowadays. COVID, Melissa,
Because
everything.
persons are convinced that COVID-19 was a lab thing that went bad. And there are some realities that we probably need to face. You see, this thing that is called biological warfare, it's not a myth. It is not a myth. And we have these countries that are constantly at loggerheads with each other. We have absolutely no idea what is going on in their labs. And so even when things come out, I am sure they're not going to say, yes, this is true. Everything is going to be labeled as conspiracy theory, just like how when the COVID-19 vaccine came out and persons had questions, rather than to respond to the questions and put people's mind at rest, they labeled the persons who have questions as anti-vaxxers. So it's how we respond to the queries that comes forward. So as you're rightly saying, Daniel, the lab is a very busy place and there is no telling what is coming out of it. Yes, Cindy. Cindy, your mic is open. So there are some social realities that we have to look at and we need to respond to those. And the policy environment, particularly in the 21st century, what is it that they are going to be coming forward with? How are we going to respond to these? Or will the population actually respond to some of these policies that are being put forward? So when we look at the whole business of why renewal, why is it necessary for us to look at the whole business of the renewal of health promotion? There are several forces that we have to take into consideration. So there are challenges and there are implications for these challenges as it relates to health promotion. We can look at persistent inequities despite decades of health promotion. So though health promotion has been around for so many years, a lot of work has been invested in it, we do still have some problems because there's a need for a stronger focus on social justice and health equity. And even though you have the health promotion practitioners, we are not operating in silo. You may not be in a position to sit at the table that determine the policy and the content of the policy. So there is always that constant challenge that is there. Globalization, trade and marketing of unhealthy products. Yes, stress on the unhealthy products. Call for multi-sectoral action and health-oriented public policy. I would have seen where some efforts are being made here in Jamaica, spearheaded in particular by the Heart Foundation of Jamaica. Now, Cindy, can you share with us anything that is happening in St. Vincent and the Grenadines? She's online, I saw her. Mic was
Miss,
open
can you
before.
repeat for me, please? I was just going in my car, so I didn't hear what you said properly.
Okay, so we are looking at the whole business of the need of for there to be a call for a multi-sectoral action for healthy-oriented public policy. And I would have made mention of in Jamaica here, where the Heart Foundation is really behind that particular campaign, where they want to see things change so that the nation can have choices and they are aware of the choices that they are making. So for example, they reduce sugar in drinks, especially those that are being sold to children, and some of the big products that we have in the supermarket where they are pushing for the front of packaging labeling. And so I was asking what is happening in St. Vincent and the Grenadines regarding that.
Oh, so in terms of health and with the children, what we had started doing is changing up the school feeding program in the primary schools mainly, where they are part of a program where they're only allowed to use natural seasonings because of everything that is allergies and the unhealthy stuff. So this school feeding program are only allowed to use natural seasonings, which is a base off and on, because natural seasoning for Caribbean people who have flavorful palate, and in our homes we don't really use natural seasonings alone. We use the pre-pack seasoning, the Maggi cubes, and they're introducing more fruit days, reducing the juice that we give. We push for more local juices now and fruits at least 2 days per week in some schools. So while that is a good initiative in terms of steering the health of our children, starting there, it's a pushback because now the children are not accustomed to those. They say the food is bland, and that's not what they're accustomed using at home. So they have a lot of children still want to eat outside of that provided program.
And so you recognize that is indeed, so thanks for sharing. There is indeed a challenge because the effort is being made by the policymakers to put things in place for the benefit of the children, but the very parents are pushing back at these efforts, and the children have no control over the way their meals are being prepared or what is being served to them. So we do have some of those challenges, and we did have some similar challenge here in Jamaica where parents actually push back at the reduced sugar in the beverages that were being sold to their children in the supermarkets as well as in the schools. There's another challenge of the rapid digital transformation, and that can present new opportunities, or it can also produce risk. Because you have access to the information highway, and everybody now is into their TikToking and their Instagramming and their Facebooking and all of those things. You have no control over what is going out there into the atmosphere, what people have access to. So while the digital space provides a good platform for sharing information, we have to recognize that it's not just health and health related personnel that are on those platforms. It's an open platform for everybody, and you have no control over what is being posted. So though it presents an opportunity to reach your target audience, it can also pose a risk because it can upend your campaign based on what information is out there, what people are accessing. We are the whole business of climate and environmental crisis, and health promotion must engage in sustainability and resilience. Declining visibility of health promotion within the health systems. Again, we have to reassert health promotion as a strategic function, not a peripheral activity. Meaning that at the planning table, it must be a part of that process and not just be seen as an afterthought. And the COVID-19 pandemic helped to reinforce the importance of community empowerment, digital literacy, and the social solidarity that we need to engage on the table as we go forward. And so you have the renewed vision of health promotion includes the following, and we're talking about some key elements now for this renewal agenda. The repositioning of health promotion within national development. So you need to integrate health promotion into all policies. So you look at things like, for example, in education policy, and we do have some of that happening here in Jamaica. There's a healthy health and lifestyle part of the curriculum, health and family life. Health is was an integral part of the development of the current one that they do have. So they are part of the education mix. The challenge that we sometimes have though is that we do have these documents drawn up, but it's the implementation that creates that problem. And if the teachers do not feel comfortable to deliver, then it is not going to be delivered. So though it is there, it will be just placed in file 13 and sit there and gather dust. What we are trying to do when that particular health and family life education curriculum was being, when it was rolling out, we had several trainings. We had asked the school to identify a teacher or teachers that would have had responsibility for rolling it out in the schools. In some schools, they would have used their school nurses to do that. But you make a plan for a workshop or a seminar to go through it and let them understand, because we want their comfort level to be where they are able to deliver some of the topics that are there. But you find that even after you have that training, when it is time to deliver some of the subject areas, they will still call on you to come in and do that delivery. It has to do with their comfort level. So when it comes to things like sex and all of those things, not every teacher is comfortable talking to the children about it. So they will call on the healthcare worker to come in and deliver. And the truth be told is that these youngsters, because of the access to information, sometimes can wheel their fingers around the teachers in terms of some of the information that they have access to. We also have to keep in mind that as small as they are, some of them are practitioners. And so when they come into the classroom with all of those experiences and information that they have access to, they may sometimes pose some questions that the teachers are not comfortable handling. And sometimes they don't know, you know. And many years ago, even before that curriculum was as it is, I was teaching a class, it was a grade 3 class at a primary school. And we were talking about, we were doing the whole business of puberty. And a little one just raised her hand. And I said, yes. She said, then teacher, you grow here yet? No. Just out of the table. That was the last question I expected her to ask me. But she just simply asked me if my grow here. So I said, yes, baby, and move right along. So you have to be at that place where when they drop those questions on you unannounced, you just handle them with and move right along. Yeah, her name was Kamika. That was what she asked me. So I just said, yes, baby, I will move right along. So, I mean, if I had faltered, then you can imagine what would have happened in that classroom. So we have to, and sometimes the teachers are really not prepared for that. And these youngsters now are even more knowledgeable about these things than those little ones so many years ago. So I was kind of frightened when she asked, but I just said, yes, baby, I move along. Give her the straight truth and just move along the corridor. When class was finished, I laughed. I was like, my God, the little girl just asked me that question. So sometimes we do have some of those challenges. So we try to help the teachers to be at that place. And sometimes they themselves are not comfortable with their sexuality. And because of that lack of comfort, they sometimes can't do what needs to be done. We have to link with this sustainable development goals because we're talking about long-term sustainability of these programs. We also need to strengthen health promotion systems and capacity. So we have to build trained cadres of health promotion professionals. And this year I have what, 6 persons in the specialist group?
Yes.
Last year I had only 1.
Really?
Yeah. And the year before I had 3. And I was like, no, God, this can't work. I said, this cannot work. And I asked him for 10 and he gave me 6. And I said, thank you. Next year we are going to up the ante. So we really have to go along, but we have to build capacity. Out there on the field in terms of those who are practicing, we have moved a long way in terms of the number of persons working as health promotion officers. When I was working in St. Catherine, for many years, I was the only health promotion officer in St. Catherine working. the only health promotion officer. Now I can safely say that there are 4 officers in the parish working. So we have come a long way, but it was not an easy feat to get there. We have to justify why we need to have more health promotion officers on the field. So when we put in the requisition, we have to go to the Ministry of Finance and argue about it for it to even get on the establishment at all. So even when we talk about strengthening the capacity of the system, it is a process. And we have to stick with it. So we have to be fighting with government to give us what we need to do the work that they have given us to do. That's what it boils down to. So we have some of those. We have to institutionalize health promotion units within budget lines, and that we actually had to do. So at the beginning, so I think about October each year, when you have what they call a budget call, health promotion officers also have to do their budget. So they have to do their program plan, what is that they plan to do for the next fiscal year, how they plan to do it, and what is going to be the required finances or resources to carry through and submit those. I mean, we submit year after year, but it doesn't mean that we are going to get any money. Yes.
More than you need then.
Mhm.
If you ask more than you need so that the job short, then
Sometimes it drops nothing at all. Not being honest with you, sometimes it drops absolutely nothing. But we are now making sure that it is a part of the budget line. So let it not be said that we did not make a request in terms of what was needed. If we don't get it, doesn't mean that we don't do it. So sometimes the officers would get frustrated, and that every year they ask them for this budget, that when activities are to be carried out, they can't get any money. But we said still put your budget in nevertheless. Because if you don't put the budget, you have no grounds on which to argue your points and still do your budget. So we have to make it a part of the budget line. The empowerment and equity as a central pillar or as central pillars. So we have to focus on our vulnerable, marginalized, and underserved groups, because those are hard to reach. There is an underserved group that is hard to reach, and it's those who are in the prison system. A captive audience, but it's to get to them. The amount of red tape that you have to, because they're incarcerated. And you're talking about the of security. And we had a program once at the women prison, and the amount of red tape that we had to pull that year just to get to go in. And when we are going in there were like probably 3 or 4 checkpoints. I am serious. You seem to have more checkpoints at a female prison than what you have in the male prison. And we had to go through all of those checkpoints. And then part of the tokens that we had carried in, we in our ignorance were carrying some little caps. They said, because they went through everything that we're taking in, and those we could not give to the inmates. But then I understand why. Because they can't cover their face and do things that they ought not to be done. So you have to think about everything that is involved. So you talk about that collaboration, that partnership and the discussion. You can't just sit in your office alone and make those decisions. You have to have that discussion with the organization before you can actually move in. So it was very difficult to get into that organization, but we were allowed in and we did quite a lot with them. We look at the numbers, helping them to know their numbers. So we did checks for diabetes, hypertension, as well as cervical cancer, because they were not able to have easy access to that kind of care. And so we have to do that for them. So sometimes we have to take the service to them because they cannot come out to access the service. And so
presentation for them. For that, basically, like each of your presentation, if you modify it depending on your audience, what would you have to do differently?
they're adult audience. So you, in terms of looking at a disease condition, there's not much in terms. You just tell them what it is and the etiology, the transmission, signs and symptoms, what they need to do to prevent in terms of healthy lifestyle practices. But we also have to remember that because of where they are, they don't have control too much over things like their dietary intake. It is what is served that they are going to have to take. So you'd have to have that engagement, with the authorities in terms of what is it that they need to prepare and serve them to ensure that they have a healthy and balanced diet. So it's a long process, and you have to go through a lot of different things to get there, but we still try. We also want to promote participatory governments in the health decision. So health cannot sit by itself and make that decision. When we are going to the women prison, we also carrying Ministry of Labor and Social Security as a part of the team that went in. And so they were able now to discuss with them social net benefits that they can access and have access to. So it has to be a collaborative effort when we are going into some of these institutions and to help institutions to understand their role. Talk about the whole business of digital health promotion, leverage technology, social media and e-health for behavior change and community engagement. We have the platform that we can actually utilize. And I do know that the Ministry of Health has a presence on most of these social media platforms. And so they have access to the information from that end. And we have to also guard against the misinformation and digital exclusion. What we mean by digital exclusion, we can't focus all what we are doing on the digital platform, because you're still going to have that segment that do not have access to the digital platform. You yourselves know that in some of the health facilities that you work in, there's no internet service. So we have to make an effort to meet. So it's a multi-strategy approach that we have to actually take. When we look at cultural relevance and the contextual adaptation, we have to recognize that effective promotion must resonate with local values, language, and norms. We have to take into consideration the cultural nuances at different levels. So even here in Jamaica, you have there's culture within the culture. What may obtain for an inner city community may be is different for our uptown community. You find that the lower level communities, they are more receptive sometimes. They are more willing to listen to you. You see the ones uptown, they peep through the window and they drop back the curtain. And you'll still say you're not until thy kingdom come. Or release the Doberman. So different audience, different things will happen. Within the Caribbean, Nicole, your mic is open. We're hearing everything she discussed with the patient. Within the Caribbean, this can include using things like music, storytelling, and community-based leadership, and we have touched a little bit on that yesterday. Evaluation and accountability, this is where we often fall short. We have done a lot of work, but in terms of evaluating the impact of what we would have done, that this is always not happening in a proper way. And part of that is because when sometimes the programs are being developed, they did not build into that evaluation component, and so sometimes we don't get that part done. So we have to move from activity-based measures, like a number of workshops, to impact-based evaluation. What are we seeing in terms of changes with regards to behavior and policy? That is where we actually need to get, when we are looking at the accountability and the evaluation component of that. And we are going to be touching some more on some of those when we do health promotion too. So what is it that we know at this time? We know that much of health is influenced by social factors. We also know that the region of the Americas has high levels of inequities. We also know that inequality can damage people's social cohesion. And one of the things that we have to be guarding against now is with the aftermath of Melissa and what is happening on the ground. If we're not careful, we are going to have the inequality in the social cohesion and the distribution and all of those things. And there's rumbling already taking place. So we are hoping that the government will always put a lid on it, because everybody has been affected in those areas. Whatever is happening needs to be done in a way that it is humanly, socially acceptable. It can't be that politics be a part of the distribution, because if that starts, you know what is going to happen. Health promotion approaches can help alleviate some of the inequities which often impact health in a negative way. And the evidence suggests that good health requires action on the social determinants of health. You notice how often the social determinants of health surface it is really the platform that should guide what we are doing, especially with health promotion. So when we take a closer look at our current situation, we recognize that vector-borne diseases and lifestyle diseases, much of it is influenced by social factors. And with the advent of what just happened, we have now to be gearing up for a possible dengue outbreak. We also have to be thinking about typhoid and leptospirosis, because typhoid is endemic in some of the parishes. Yeah. Every year we have a few cases. So we have to be thinking about those in the kind of situation that persons are now in. Infrastructure totally destroyed. You talk about solid waste management. It is extremely important for that, for the government to step on that, or your local authorities to step on that, if we are going to minimize any of these things surfacing right now. And how do we manage when persons don't even have anywhere to sleep? These are some of the realities that we are faced with. But in the same breath, we don't want to have that happening, because that is going to be adding fire to an already raging inferno, and we don't really want to have that. When we look at inequities, we can look at what is happening uptown versus downtown. What goes on uptown is totally different from what is happening downtown. The kind of things that persons uptown have access to, those downtown may not have access to it. The kind of things that they are willing to invest in because they have the resources, those downtown may not have the resources to invest in that. The challenge though is that sometimes those uptown do not see investing in those downtown as a means of protecting their own health. I don't live down there, so I want to, but when anything pop off down there, I can tell it is going to climb the road, and it is going to go uptown. But sometimes I do not see it from that set of lens. Like they are down there, I am up here. So the two things never come together. Urban versus rural. What is available in the urban center versus what is available in the rural setting? One Caribbean country versus another Caribbean country. And we can look at what is happening with our Caribbean neighbors right here. What is happening in Haiti? What is happening in Cuba? Where does the rest of the Caribbean come into part of that helping my brother get to the place where my brother needs to get? We know that Cuba is constantly under embargo from the United States, which is crippling their economy to a great extent. There was a time when they were getting a lot of support from Russia, but that was when it was USSR, the United Soviet Russia. Since they have had that dismantling, I do not know the extent of the support that they are getting, because the Iron Curtain fell and there were some countries that pulled away from that union. So it is no longer a union as it used to be in those days. We also have the whole issue of what is happening now with Venezuela. And we better believe that if they start a war down there, the whole Caribbean is going to be a blanket. It is going to have implication for aerial travel within the Caribbean. It is going to have implication for the countries that depend on oil from Venezuela to do their business. Now, what a lot of persons sometimes don't realize, that although they may not be trading directly with Venezuela for oil, the countries like Mexico and probably Brazil also that they are buying oil from, those countries are getting their oil from Venezuela, because what they have as deposit is not enough to serve their own country, much less to import. So they are getting from Venezuela, because Venezuela has the largest deposit of oil reserve in the world. Wow. So Trump has sounded the trumpet, and he is down there picking off some boats that are claiming that they are drug traffickers, and warships are down there. Why would the United States government deploy their biggest aircraft carrier down to the Caribbean? Is something that we need to think about.
They control Guyana oil. America basically fully controls Guyana oil, and Venezuela is threatening to take part of Guyana, including the oil.
And so that is what triggered the whole thing.
Their oil. They're not protecting Guyana oil.
Yeah, there's not on their side.
Yeah.
But those are some of the geopolitical issue that comes into play. So if when we talk about what is it that we need to do to reduce inequities, it's not in a silo that we have to look at what is happening. We have to look at the broader picture and the impact it is going to have. So those of us who are Christian, we need to pray and pray hard that no war don't start down there.
Definitely.
Because every one of us in the Caribbean are going to be impacted in a very negative way. So we have to think about those things. So when you talk about health promotion, we are not just looking at health issues and then we're going to do something. It's a wider, broader perspective that you have to bring to the table. Inequities can cause breakdown in relationship, and people are less likely to work together if they don't have that cohesive relationship going with them. Given the fact that health promotion is a cross-cutting discipline, means that it's not just health alone that can do what needs to be done. Efforts are being made to use health promotion to alleviate some of the inequities. And so we must keep in mind that much of what influences our health is not found within the health system. The social determinants of health comes back again to the fore. And so we have to look at the renewal within the Caribbean context and the fact that at the 30th anniversary of the Caribbean Charter for Health Promotion, and that was the PAHO conference in 2023, regional stakeholders recognized the need for the renewal. And so health promotion structures in many countries have weakened over time, and that was some of the issues that they were actually looking at. The fact that non-communicable diseases, climate threats, and inequities remain a major concern for the Caribbean, that there's uneven implementation of charters, the Charter's 6 strategies across the nation. So it would have looked at the 6 strategies for the Charter. Across the region, it is not being implemented in an even way. Some countries are ahead of some in terms of its implementation. And the COVID-19 pandemic really brought to the fore gaps in our communication, the trust within community, and the digital readiness or lack thereof. That is part of what is happening in the Caribbean at this time. And so we need to take a look at the link between the Caribbean Charter and the renewal of this movement, which is the renewal of the health promotion. In the Charter, which is the Caribbean Charter of 1993, that's when it was developed. And what is the renewal agenda? We're looking at 2023 and beyond. Emphasis on empowerment, supportive environment, and alliances was a part of that Caribbean Charter. So there's now a renewed call to strengthen social participation, digital advocacy, and governance. We are also looking at the regional response to the rising cases in the non-communicable diseases, and the fact that when you look at the renewal agenda, there's an expansion to climate health, digital health, as well as equity. When the added focus on the media, which is a part of that agenda, was looked at that charter, we recognize that there needs to be a renewed focus on the social media and the digital storytelling. A lot is happening on that platform or those platforms that can either hinder or enhance what we need to do. The regional adaptation of the Ottawa Charter, we will look at the fact that there needs to be the realignment or the alignment with the global framework like these SDGs, and also implicit emphasis on sustainability. We can't underscore that enough. And so the explicit inclusion of sustainable financing and intersectoral evaluation is all a part of what we need. And so you find that with the 2030 agenda here in Jamaica, I know that the Ministry of Health has to submit a report on a quarterly basis to the committee that is spearheading the implementation of that particular development agenda. So everybody who have all the stakeholders in it, and so they need to start the table to see whether or not the things are rolling out the way it ought to be rolled out, and what needs to be done where gaps are. There are a lot of gaps in health, and I don't know how they plan to fix them, but I hope the fact that they are sitting at the table and looking at it, it is not just a meeting for the sake of meeting, but meeting with a purpose to do something, to actually have something actionized to fill the gaps that would have been identified. So the regional priorities would include the reinvigorating of the community empowerment, which goes beyond participation to genuine ownership. What we really want is for the communities to be so empowered that they take ownership of. Because we really don't have the manpower to be there at all of the community levels to really spearhead what needs to be done. So the communities need to take on that ownership. There needs to be strengthening of the intersectoral action because we really want to embed health in all policies as part of our national planning. And we need to harness the media and the technologies that are available, particularly for our youth as we engage them. That's the only platform we're really going to find the youths. And even when they are in universities studying, you find young people don't even really visit some of the platform that provides them with the information that they need to even sometimes do well in school. But they are on the TikTok and all of those things, and anything on TikTok is gospel. Another thing where the whole business of the media and technology is concerned is that sometimes you may have some particular professional discipline that, and let me not say that, let me be specific. So for example, we may have like our doctors. They would have been out there practice. What they need to understand is that we are living in an age where patients are going to be coming in because they cannot write the prescriptions themselves. Because they would have gone to Dr. Google, they would have done their research, and they would have looked at the kind of medication that is required to get them back to that state of health. So when they come into you as a medical practitioner, they are going to be telling you what is wrong with them and what they want you to prescribe. How do you handle a situation like those? Do you throw them through the door and say, I am the professional, and if you're going to be telling me what to do, then go ahead and do it yourself? Or you're going to be using it as an engagement platform? Have discussion and dialogue with them. How did you arrive at that decision? And they're going to be telling you where they get their information from. So you engage them to know where they have gone to for their information. Now you can't throw them out the door with the information, because when you were in school, where did you consult to write your assignments? And if that information was incorrect for them, it should have been incorrect for you too when you were doing your assignments. But in the middle of all of that, we have to understand that there's also misinformation on those platforms. So when you engage them in that discussion now, you find out whether or not they're getting their information from a credible source, and you take it from there. So we talk about the whole business of engaging, especially the young people. Because gone are the days when they just come to doctor, like old people like myself, and whatever the doctor tell you is gospel. No, everything you know is being questioned.
For them to ChatGPT tell me this.
Yes, ChatGPT give them a whole lot of information. So we have to be at that place in our engagement with them where we recognize that they are not coming to us as blank slates, but they are coming with information, be it correct or incorrect, and we need to have that dialogue and that discourse with them. So we talk about the whole business of a renewal of health promotion. That's a part of what we have to now say to our practitioners, that remember that these things are happening. How do we embrace it and use it for the advantage of the patients? We have to get to that place. When we talk about building sustainable financing for health promotion, we need to structure it in such a way that what is happening is not ad hoc. And too many times, some of our campaigns and our financing depend on external forces or sources. If we depend too much on external sources, there's going to come a time when that is going to dry up. And a very typical example is the HIV program. When those started here in Jamaica, they were all externally funded. It started out with the Germans, with the GTZ program, and then they moved to USAID and UNAID. Now these the German program pulled out a long time ago. The USAID and those programs have been there for a long time. Now Trump is in office. Trump asks him a whole bag of questions and can't get no proper answer. So you know what I'm doing with those organizations. He said, look here, no more money than I get. And especially in light of the fact that quite a number of those organizations are the source of funding behind things that are being done for the at-risk group, the men who have sex with men, and the gay agenda. Trump not in and nothing with that. And he
Well,
used
not
that as his reason for just
necessarily.
cutting the funding. What was that?
Oh no, I'm just saying the cutting of USAID is still not necessarily a completely bad thing, but that's a more political argument.
Okay, that's debatable. And I take your point. But
No,
It's
I
a
mean,
bad thing
remember,
when the government, hold on, Walter.
It-
It's a bad thing when the government has no intention of taking on any of what was being done. Because I can tell you, Global Fund was supposed to pull out of Jamaica from 2020. Because of COVID, Global Fund decided that they were going to continue. And when they eventually decided that, because the plan was always that the government would take over much of what Global Fund was doing in terms of social support for Jamaicans. The government has not taken it on. So
So
and that's
currently,
exactly
if you
what we're
ask anybody,
saying.
even without USAID, because this is new, this is since January. So even without that, since Global Fund pulled out at the end of 2022, much of the programs that we could have done for patients, we are no longer able to do. And when you ask the government, they are not filling the spots. In fact, it was some of the same like CDC funded partners and CTEC who ended up trying to take up some of the slack from what that fell off from Global Fund. So that's the problem we have.
And,
The government is
and that's
refusing,
what we're talking about.
even when you think about staffing, even staffing, things like evening clinics, some of those very evening clinics that you are seeing for HIV. I can't speak specifically for HIV because I know it's still being funded by external partners and the government. If the partner them stop for 2 months and don't pay, it's like the government don't lost and they don't have no intention of paying for anything, which cannot be the case.
And that is exactly what we are saying, is that there needs for there to be the building of sustainable financing. And we know that that is not in place, because even with Global Fund, many years they have been talking about the fact that Global Fund would have given them a deadline within which they are going to pull out. And so they were supposed to put position in place to absorb the staff as well as take on the other things. And they had years to do it, and it was not done. So here we're talking about some of the challenges that we have in terms of even the renewal of health promotion is a lack of sustainability of financing. I have had the unfortunate experience when I was working on the field when I was in St. Catherine, where we had World No Tobacco Day was always funded by PAHO. And we know exactly how much we were getting from PAHO. So they have gone into administration and they would have said, yes, go ahead and do the planning. And we will put the money up front until we get that reimbursement. Because for PAHO then, you have to execute, submit your report, and then they release the money. Everything was in place, well planned. The day before the event, when I went to administration to get that $5,000, and then time the $5,000 enough money.
Jamaica?
Yeah, I have enough money them days. It's not like no. To execute the activity the following day, they were going to tell me that they don't have any money. And I'm dead serious. Everything was mobilized. I actually had to go into my pocket to do the activity. And they did not give me my money back until they get the check from PAHO. And I kid you not. But oh, do you let something at that late stage go down the tube? You have to look at your credibility that is going to be on the line, and you can no longer have that partnership with those groups because they are going to say that, oh, after you plan something the day before, after them do everything, I mean, everybody ready. So sometimes as healthcare workers, we are placed in that very uncomfortable position because they do not build sustainable financing, and they talk about health promotion being the platform on which a lot of things should be done, but they are not funding it the way it ought to be funded. So the realities are there, and I understand where you are coming from, having worked many years on the field and having been subject to what you are talking about, where we have difficulties getting funded. We also need to monitor progress through measurable indicators that are aligned, as we said before, with the sustainable development goals. So while the challenges are there are also opportunities that we can actually look at in terms of the renewal of health promotion. So there will be factors that support health promotion, and the converse is also very, very true. When we look at challenges, the first one we can take a look at is disorganized urban growth. Anybody want to talk to me about that one? Disorganized urban growth.
Everybody wants to be in Kingston, and now they're just putting high rises in areas that were not originally accepted for high rises. So you're having a high rise next to your normal flat house.
So you have no privacy anymore.
No privacy. Some of the areas are actually protesting against it, but the high rise, people have money. So they keep getting to go through. Because multiple times in here where there were like stop orders for like a short time because the residents protest, but then in the end you still see it go through, like it never actually got canceled.
So money makes the mayor go around. And in addition to those high-rise buildings going up, the infrastructure that is needed to keep pace with them is just not there.
Look at traffic.
Oh, sorry.
So,
Yeah. That's what I was going to mention in terms of the high rises going up. Thinking particularly along like what you want to be called Wellington, where it is just going to have a lot of persons living there, going disparate places, and everybody's just going to have a car for themselves, and it's already just kind of a congested road as it is. The air quality is going to be poor, the quality of life is going to be poor because all the traffic that's going to be there, it's just going to be miserable.
And the drainage system is not set up for the number of buildings.
So that's why they dig up the road and put everybody out on the other road. What I think that these successive governments have not done is proper forward planning. So we know we are living in an era where people are living longer. So the old people like myself now dead so far, so they pick them get the house. So they are going to need to get their own homes, right? They have to get somewhere for themselves, and the grandparents them have to get somewhere for themselves because we are living a little bit longer. So there was no forward planning to cater for that. And so you find that even when they put in the drainage system, the sewer system, it was then designed to cater for just the population at that time. They had not looked forward to see that there's going to be an increase in the population, an increase in the demand. And so you find that now that they're putting up some of these high-rise buildings, the current infrastructure was not designed to carry this capacity. And so the problem now exists. That is what is going on Monroe Road now. Or Wellington, whatever that road, I think it's Wellington. Because you have several high-rise buildings that are going up on that particular road. That sewage system and the pipeline wasn't designed for that volume of usage. So it is no longer going to be able to manage what is going on there. So those things are happening when you come to the disorganized urban growth. Those are some of the things that are actually happening. So they have to put in sewage system. If you look even at the Kingston Public Hospital, it was designed for a particular population level. The volume of usage of that facility now way outstrip the facility itself. Yeah. They don't have enough beds. So even like when you had like the COVID-19, they never have enough beds to collect the patients. When Melissa was coming, you know that normally when you're having disasters like those, the hospital do a lot of discharging. And a friend of mine, her sister, who apparently had some gallstone kidney, some such related matter, went to the hospital the Monday. She was sent home the Tuesday, and she died Tuesday night. Just like that. The family is distraught because they're saying that the hospital ought not to have sent her home because they told her that she needs surgery, but they still send her home. And one could understand and I'm trying to help them to understand that with a disaster threatening the country, there are some hard decisions that have to be taken. Unfortunately, there was a demise in the middle of all of that. But they would not have been going into or planning any surgery at that particular point in time because they have no idea what the impact of the system is going to be on the hospital system. And we have to have an appreciation for the fact that the hospital, even in crisis, they are still a responder because they must respond to all of the casualties that are coming into them, even when they are trying to cope with the impact of the system. And sometimes as citizens, we don't understand that. The only thing we can see is that it is and my person sick, I need to go there, they need to go there, and they must be treated. So we have to try to help them to understand that it's no comfort, but that is the reality. So we have some of those things here where the population now has outstripped to a significant way the resources that are available. How do we catch up and then keep pace in going forward with what is happening? So we are faced with some of these. And as you would have said, Daniel, it has impact on the health of people because the amount of dust that is on that road and all of those things, that you can imagine the houses that are on that. Every day the dust, and before you're finished, the dust is back on the furniture. If persons have respiratory illnesses, the impact it is going to have on them. So we do have some of these things happening and it is impacting health. So it goes right back to the determinants of health. What determines people's health? What is in their control versus what is outside of their control? Policies sometimes do not adequately address the root cause of people's ill health, and the multi-sectoral action is always required. And because of a multi-sectoral challenge, action, it is a challenge because sometimes everybody is coming to the table, but they're not working together. So they're sitting at the table about each planning, what can I do in my little space, because it's a matter of who is going to get the accolades.
In environmental health, now we have the panel. They gave a clear disclaimer that even when they come to the table, all they can do is give suggestions. And at the end of the day, the suggestions, like they would suggest that they don't think that high-rise can go there, it's not acceptable. Therefore would agree with them. Solid waste might agree with them, but then when it reaches to the politicians who are friends with the developers, all they could have done is say they write up their recommendation.
And that's the most that they can do. And the example that we can also draw on to is the whole issue with the fish kill in the rail recovery.
Yes.
And that cooking up behind the scene and the outcry, and they had to come back to the table. So I don't know how much the company actually end up paying, but certain sectors just never accepted that behind the scenes settlement that in no way could have helped in terms of trying even cleaning up the disaster that was there. So you are correct when things reach a particular level. So again, it goes back to the political will. Though we may not want to work with them, they must be a part of the agenda because they bring a lot to bear to the table. So sometimes when they do meet, and then when you have the multi-sectoral, each organization is coming to the table, but they are thinking about what can I get out of this? When we come to the table, we sometimes don't see that partnership and collaboration as everybody sharing in the glory. Some persons do not wish to share their glory. So they want to say that it was my organization that did this. And so even though they sit there, that silo thinking is still going on in there. And so what should have been a collaborative effort sometimes is not really collaborative, and that can be a challenge in terms of the renewal of health promotion. And again, poor communication among sectors. Sometimes that communication that needs to be happening don't happen in a timely manner, and it can also trigger issues. Powerful influences of some industries that you'd have mentioned where the political people can come to bear: tobacco, alcohol, and food. And we would have looked at what was happening or what is still happening with our foundation and the packaging of front of label packaging, and the fact that they are adamant that there has been political interference and they were not afraid to call names. They actually did. So she was very fearless in terms of coming to the board. With tobacco, when it was supposed to be passed into legislation here in Jamaica, I remember a member of parliament saying that he had no problem with tobacco legislation, but he had a problem with some of the things that were in the legislation. And one of the things that he had a problem with was the fact that they were saying that smoking should not take place in the homes. And they did that against the backdrop that children are there and household helpers who need to come in and their exposure to the second and third hand smoke. And he said that his home is his private space. And he's supposed to be entitled to do whatever he wants to do in his home. I was a politician. No, that now get passed nowhere unless that was addressed. Eventually they had to take out that clause out of it. So we talk about the political will to get things done. The entertainment industry and some of the songs that they put out that would hinder what we are doing, and I use those examples, the gal in a bungle and me a rub on me bleaching cream. Yes, some of those things. So when you have the entertainment industry endorsing the unhealthy behavior and the people see them as their idols, it's a part of their entertainment, it's a part of their identity, it's a part of what they are doing, it is going to pose a problem. So these things are going to hinder the whole business of what we need to do. The lack of evidence for the effectiveness of healthy setting approaches, and we have lack of evidence because we are not doing the proper monitoring and evaluation that needs to be done so that we have the evidence to say this is the outcome. And so it's struggle is real to promote healthy behaviors when you are going up against industries that has money. It was not easy to get past Carreras with the tobacco legislation. There were many meetings. There were many meetings. It was not easy to get past them. They can influence through different means from the policy level all the way down. We see them sponsoring all kinds of events, especially poor sporting events. And when you have, well, the summer thing that usually happen in summer, everybody, young people get up during the summer. Dream weekend and those things. They have booths that they set up at these different events. And those booths, what they are giving out is free. It's not that anybody had to buy them. The alcoholic beverage companies do that too. So them have free access. So after they tantalize and stimulate your taste buds, then you are now going to be willing to go and purchase. And so part of what they had to look at here in Jamaica is that tobacco industry no longer be a stakeholder in funding any sporting event. But having said all of that, we start to tax them and take the money from them and put it in a little space where we say we have access. What is the Chase Fund? It is funding. So Chase Fund is getting money from the tobacco and the alcohol industry. That's where that funding is coming from. So if we are going to tell them that don't sell it, then we're going to take some of the money after them sell it. I don't know, but that is what is happening. In some regards, we do not have enough research or even evaluation of programs, as was said before, but I'm happy to say that we are looking really a lot more at research. What we need to do is to get those research out into publication. And over the years, the Ministry of Health would have been having what they call a National Research Day, where research persons who are doing research are invited to come and share what they are doing. But it's only a small audience that really have access to that particular bit of information. So we really need to go into publications. Hence my cohort here, that I am hoping that every single group will make at least one publication from the research that you are doing. And we're serious about that. And I'm sure Dr. Thompson would have spoken to you about it. So we really want, it doesn't make sense to come and do all of that work and just sit down and just gather those. Let your name go out there, man, so somebody can see you and say, oh, you know, I was looking at a paper that you published. Yeah, we're going to get the accolade. So let us put it out there for others to actually see. You do invest a lot in doing those theses. They need to be out there. In the middle of all that is happening, we still have opportunities that we can actually work with. And so we can look at the adoption of the 2030 agenda for the SDGs. And this agenda for sustainable development is an important shift from disease-oriented development to addressing all sectors. And we look at the whole business of the economy, we look at the environment, and we look at social development as integral part of what we need to do. So there are 4 strategies for the renewal of health promotion, and these were outlined by POW in 2019. They speak about the re-energizing of key healthy settings. They look at ensuring community participation and empowerment, as well as the engagement of civil society. They look at how can we enhance good governance and intersectoral work, and address the social determinants of health, and strengthen the health system and the services through health promotion. And we are going to be looking at those in detail. So when we talk about the re-energizing of the key healthy settings, key settings that should be in universities, the communities, the workplaces, the hospital, our health centers, churches, prisons, markets, you name them, and we need to have a look at them. Why? Because we're talking about where people live and they work and they play and they do all of these things. So that is the setting. So we have to adopt the settings approach. But this needs to be systematic in how we do it. So we want to enhance or establish healthy settings, networks, and initiatives, because that will help us to build capacities at all levels to implement healthy setting guidelines. And when we look at a settings approach, there's an assignment in health promotion too that is always given where you actually have to do that assessment of a facility. We have done markets, we have done schools, we have done workplaces, we have done health centers, we have done hospitals, and we have also done even restaurants. What was the offering that they actually have? So, and we have done churches as well. The prison now is not easy to get into, but I do believe that we do have 2 persons in this cohort that actually hails from that workplace. So we may just jolly well look at that one because they already have a footing. That's where they work. So we might look at how it can be built out into a health promoting setting. So those who are from the prisons, I'm just giving you a heads up that might just be on the agenda for our next health promotion too. When we talk about ensuring community participation and empowerment on civil society engagement, we really want to ensure that there's participation, that a community should be given the right as well as opportunities to make effective decisions regarding issues affecting their lives. There is conventional wisdom in every community. Means that the people already understand the issue and they also sometimes know the solutions to the issue. They just need a little help in advocacy and networking to get it done. If you have that discussion with them, they'll tell that boy, we think that if this and this get done, then you can solve this. But sometimes it's not, they don't have the wherewithal. It's that they don't have the supportive environment to do what needs to be done. So I really want to empower them because this is really important and they need to be a part of the process and continuous assessment of the community to provide the support that is needed. We have a tendency where we just sit in our office and we want to plan something and go, and we just go. We want to move away from the dependency and the mendicancy. We want community members to say, hey, we can do this for ourselves. Just give us a little support. But often we just take things in there and we do this handout, and when we come out, the people don't say, hey, they were not a part of it. So that interest in its maintenance is not there. So we need to move away from some of that. We want to look at a more meaningful engagement with civil society because this is needed if we are going to really make an inroad in terms of improving health promotion. So we need to develop specific programs and materials to promote informed and empowered population. That is one of the reasons why you find that in the Jamaica Moves program, they work with the Ministry of Education and they work with other organizations. And I want to tell you that out of that particular interaction and the multi-sectoral approach that they would have used, things were happening. The youngsters were doing their gardening at school. They were having like their water day or their fruit day. So the youngsters were enthused and they were doing things at their level. But then there came COVID-19.
Before that, we were the scandal first. And you were the scandal before the COVID.
Well, the scandal never really impacted so much because when big people something that. But that was big people something, but in terms of what they were doing on the ground, and even when we started with 100 schools as a pilot project, and there were schools that were calling, asking if they could be a part of it, if they were not selected, even though they were not selected among the pilot, because there was a healthy jealousy because of what was happening in other schools. So we had some of those things that were happening. And if you have a good program that is showing impact, others are going to want to be a part of it. But COVID-19, that young man, I'm not calling him a girl. No way. Melissa is enough in not calling that one a girl. No, 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 no. When we look at the whole business of good governance and intersectoral work and the whole business of addressing the social determinants of health, we need to address issues that exist between the population needs and the response from the health sector. And we have to remember that there's a thing called felt need and normative needs. Normative needs tend to come from the persons who are working in health. We look at the epidemiological data and we make an assumption as to what the needs are. But the felt need is what the people themselves think that they need. And there's a difference between the two. And too often is the normative needs that drive things. And then when we don't get the cooperation and the participation that we need, then we complain. But if we had used felt need as the driver, then we would have gotten a better response from the people. We also need to create synergy between health promotion, the social determinants of health, and people's human rights. We can't leave those out. But even when we talk about human rights, sometimes people will say that the government is high-handed and some of the things that they do, but it depends on what is happening. There are some things that are going to require an authoritative management style, and something that can be open to our democratic approach. COVID-19 could not have waited for a democratic approach. So it depends on what is actually happening. Some things may require a change in management style to address it carefully. We need to build the capacity of the professionals with responsibility for health policies to support development of goals across sectors. So if we get one minister of health who don't have a clue about any of these things, we're not going to get anywhere. At the local level, if you are planning your thing and you don't keep HR on account, and the account department and that planning team, you're going to have problems. So here we're going into the workplace, talk about workplace wellness. And HR was not involved in a lot of the organization in terms of the planning. So when it was no time for them to give the workers the extra 30 minutes off work early, so they can go participate in the exercise, it wasn't happening in many regards because HR never understand the whole business of the impact of workplace wellness on productivity. So when you're going to be forming those committees, and remember, health promotion is not about no one-man band. It is working as a team to get things done. So whenever you're planning anything in your organization, 2 team members need to be on your planning team. Those from HR and those from accounts department. Accounts don't like spend money, even though it is not coming out of their pockets. They do not like to spend money. So if they are not a part of that planning process and cannot see the need for that investment, you are going to have problems. I ever think it's what we're making? Try it.
Whatever COVID is not their money.
But they are the ones who sign off on the documents.
Even if you get like a sponsor, they feel.
They are the ones who sign off on the documents, and if they don't understand the need, you will have a supplier waiting 6-7 months to be paid after they would have given their service. I remember working with one facility and we needed something as simple as an electric kettle. It now costs more than $1,500. It took us months to get it. And we needed it because we were having a GE outbreak. And when the children are coming to the facility, you need to make sure it's clean water using to reconstitute the ORS to give it to them. It was a struggle. $1,500. We have to back up the little accounts man and give it to him one day to get the little money to go buy the kettle. So it is very important to have them as part, because when they're sitting at the table, they will hear quite a bit and they understand their role as a part of the process. So sometimes we plan them out of it and then we expect them to just come and support. No, just like how we are planning with the people for the people, plan with your HR and your accounts department.
The legal too.
Hmm?
For the legal too.
Yeah, plan with them. And make sure that when they meet, they're not scrolling on their phone, they're listening to what is happening. Because some of them will tune you out, you know. They must literally tune you out. So they're there, the body is there, but the mind is not a part of the meeting. So you have to work with them. So call on them. What is your suggestion? How do you think we can do this? You let them be integrally involved. So it's not just the target population, but also the members of their stakeholders as part of your team that needs to be there on board from day one. There needs to be strengthening of oversight responsibility at the regional health authorities and at the Ministry of Health levels to address the social determinants of health. It doesn't make sense we're down on the ground doing things and it's not coming from the top, because at the end of the day, they have monitoring and evaluation oversight. And so whatever we are doing there must also be in keeping with the national objectives. So as a promotion officers, what I would do when I was working as a regional person was to call into the ministry, what is the focus from the ministry perspective for this calendar year coming up. And then we look at what is happening at the local level and we do the bridging of the gap. So that at the end of the day, all that we are doing is also feeding up to them, but it must also be helping them to achieve their objective as well. So there have to be that communication and that working with at all different levels. We need to provide a comprehensive approach to health and health care. And I think some efforts are being made in this regard. And policies must be developed or strengthened to reduce inequities and inequalities in health. I think they are trying, but we have a long way to go. But they are actually trying. When we look at the strengthening of our health system and its services through health promotion, health must be viewed as a right and kept at the center of the planning, and the sector must expand beyond responsive care through clinical and curative services to increase health promotion initiatives through national policies as well as guidelines. So we may see a lot of initiatives coming out of the different health centers that are at the different levels. You may not see a health promotion specialist per se, but because other members of the health team understand and they know the roles and function and the things that need to be done, they are part of the process, because you don't have enough health promotion specialists to be in every facility to carry out the task. We also have to conduct community-based assessment to determine impact of health promotion policies on community health. So we can't just sit there, we also have to work at the local level. So if you're going with a program and you're the health education officer saying that they're going out to do a needs assessment or a feasibility, so there are SWOT analysis, they're gathering the data. Because sometimes we get the epi data, but we also need to know what is driving what we are seeing in those areas. And unless we can find the root cause, then whatever programs we go with will not solve the problem. Because at the end of the day, we are seeing the things at the top of the tree, but we need to see what is going underground to be fueling the growth of the tree that we are seeing and the branches at the top. When we look at the health system, the health services need to be culturally sensitive and facilitate collaboration across sectors. There was a time when the young people couldn't come into the facility and get certain services because of healthcare workers' biases, like family planning. So the more they have sex and they're not supposed to be having sex, so we tell them they're not supposed to have sex, and we attitude just turn them off. So the unprotected sex are going out there, and some may get infections, and some ending up being pregnant. But if you look at the whole social determinants of health and understand that we need to do what we need to do, we gave me family planning when they come, because it means then we won't have a problem with teenage pregnancy. And sometimes when you have this dialogue and that discussion with them, it's not that they want to engage, but sometimes their situation and their circumstances is what forced them into the position that they are in. And because they are minors, they don't have that negotiation power. Sometimes I write that the household the things that come from. I tell them that their parents have to give consent when it's the father molesting. Or they're going to get that consent and their mother don't believe them that the father touched them. Where are they going to get that consent from? And so we have to look at a lot of issues. And I remember one year when the government was trying to develop a policy where it's that a 10-year-old child should be able to come into a health center and access family planning without parents' consent. And the healthcare worker said, not over with dead body.
I mean, I agree with the 16-year-olds without consent, but
They had it at 10 years old, and it was a particular program that was going on that emerged out of the HIV program, and that's what they were pushing. And the healthcare workers said, over our dead body, this one not flying. And they asked them, who is going to provide protection for us when the government come down on us to aid and abet what is on the book as a criminal activity? And so you wonder about what was going to, well, their justification for it was that some of them are being molested in the household. And so they would not be able to get any consent from those within the household to prevent the pregnancy. And I understand where they were coming from. But as I said to them in that meeting, we are addressing the branches. We need to get to the root. So if the child coming at that age, then we need to call the police. No questions asked. Call the police. Because that child will need to be protected from that person within that household.
and we could be fined if we don't report.
As medical professionals, so that was one of the things that they were saying. So how do we manage this? Who is going to protect our back when the lawsuits start to come? So that one never get anywhere. I never forget that meeting. It never go anywhere. The care workers shut it down immediately. The thing is that we have a lot of laws in Jamaica, but they are not supportive of each other.
Yeah, because even when we report and CISO comes, when we check back on patients, it's like nothing will happen. Like even sometimes, for example, it's the same age, right? And you understand it's still an offense, but it's the same age. So you understand nothing really coming out of that. But even when it's big men, when the little girls tell us it's something bad and it's from the community and nothing will happen. Sometimes all the person come with the child when the 40-year-old delivery, you see the father show up quite comfortably at the hospital. And it's just so
But we have been seeing a shift though, because more and more of them are being brought to the books now before the courts of law, and they're actually
So that is what I was gonna say.
right.
A lot of them, so even though at the time when you talk about, you may not see anything happen, but it's happening in the background.
Mhm.
So where the police is called, and a lot of times I actually write up the documents for the police. And I've been getting more and more to take for them to do.
And you have been seeing more and more in the media where they are being imprisoned for those actions. So there has been an increase with regards to that. It is slow, but it is still moving along a positive direction. So we are getting some of those things. So we have a lot of laws, but sometimes they don't strengthen each other because adulthood is 18, at age of consent for sex is 16. Two of them should be one and the same age.
When it's not the same age.
No, they are not.
Why?
I don't know. It
Not
depends
there.
on who make the laws, you know. So
Me, sorry.
I don't know. It's like again, not necessarily trying to like die on this hill, but at the same time, I think isn't the 16 aging, isn't that more so supposed to be for, I guess, when it is that they're in their own age group in terms of relations between their own age group, as opposed to like, I don't know, conferring adulthood and that kind of
it's
stuff.
the age of consent to say, yes, I can have sex. And the young girls, then say they don't want nobody will get lunch money like themselves. So it's not within their age group. Yeah, they tell that they don't want anybody who's getting lunch money like them.
No, but there is an aging consideration though. There's actually an aging consideration as in age differences somewhere in there. But one of the things that I wanted to say is that even though, you know, we also have an issue because even though the law says
we keep on saying age 16 is the age to consent for sex, but it's not limited to consent for sex, you know. It's the age of majority, which also means that that 16-year-old can consent to medical care. So if they need to go to the dentist, they can go to the dentist on their own as well. But we also have a problem because even though the law says if I'm 16 and I want to see the dentist, I should be able to go to see the dentist by myself. There are some places that you'll go that nobody wants to assist. Even though the law says at 16.
I know
So-
that they are not allowing them to sign no form at age 16. They're telling them for them
No,
parents.
but the law says that the child can give consent to even surgery at the age of 16. And it's a recognition that they can have the cognitive ability to make that kind of decision on their own even without a parent. And depending on the 16-year-old, they really have that cognitive ability to make the decision. And we need to accept that that is possible. What we need to do is provide the guidance. Now we also have a problem on the other hand. How many 16-year-olds can walk into a sexual health clinic? A comprehensive. If I see a 17-year-old, I see them by themselves. In fact, sometimes I ask the parent to step outside so I can have a conversation with the 17-year-old who has made this decision. And so I can give them proper guidance on the decision that they've made.
Part of
Because
the
sometimes the parents
reorienting of the health
interfere
services.
in the conversations, and sometimes the children don't give you all the information you need to get because this person is hovering over them in the corner. And we need to understand that whether or not we provide the space for them to come and supportive team to give them the advice and the support, they're going to have sex and then we're going to be in bigger problems. So I prefer if the door is open and they know that they can come and they're going to get the services that they need and the support that they need, rather than they're out there and they're just doing anything and they're getting everything. Because remember that 15 to 19 age group is the ones running this HIV epidemic. So if we don't have the conversations, if we don't make the spaces for them, we're going to be in trouble. We can't not do it.
Part of the reorienting of the health services was to make that space for them, and that is why you are now able to do some of the things that you are doing with that particular age group. There was a time before when it doesn't make any sense. They walk into a healthcare facility, nobody was going to be seeing them without their parents. But the recognition was there that the services were not user-friendly, especially for the particular age group, and they look at the nuances within that particular age group, and that is why they would have put that policy in place and now make it possible. So even if at 16, the child comes in and want to have access family planning, the care worker is not supposed to say no. They are supposed to have access to it. Some years ago, that was not so. You couldn't walk in there under 18 and get anything. Trust me, them lash you good and proper. And when they finish with it, you're not going back there all when you're 20. So we have some of those. So those were some of the reorienting. Pardon me?
Then again, now, like Nicole was saying, you have multiple laws and you have laws in contradiction, because then that which governs schools does not say that you can give those students 16 or otherwise any family planning.
Not in the school setting.
You're
but if they
forbidden for
come
doing
into
so.
the healthcare facilities for it, then that's a different space. But you could not do that within the school setting. And that was
Even
one
as the
challenge that
same
the
healthcare
HIV
worker.
program team members had, because when they go into the school, they weren't allowed to issue condoms to the youngsters there. But if they go into the health facility where they themselves go to seek it, then they are not to be turned away. So it was the setting now that they are going to be seeking to access that service that was going to become critical and important. Yeah, so we have those issues that we are dealing with. And so we need to train our health workforce to develop or increase their skills in navigating the treacherous waters, especially with our youngsters. There are some other things that need to be considered. We need to look at focus on holistic well-being. So we need to promote things like mental health, people's emotional, physical, and social health as being interconnected parts of the overall well-being. And as I would have said before, I noticed that mental health is now very much on the front burner, and they're making issues to look at it. So even with the devastation, I remember hearing in one of the press conferences where they were talking about efforts to address the psychosocial well-being of the persons who were affected by it. So that things are happening. Might not be at the speed at which we would have liked to see it happening, but the journey of 1,000 miles begin with what? The first step. So we are stepping in the right direction, but we have not yet reached at the destination where we want to be. We also need to encourage mindfulness, stress management, and mental health awareness alongside physical health. And stress management is a very important factor, not just for the clients, but also for the healthcare workers.
I don't think it's possible
For what?
to manage stress.
Everybody can manage stress. It's really our response to the situations, you know, that cause us to be stressed. So if we can manage our response, then we can manage stress. Seriously. But all of us goes through stress. There's nobody that is exempt. Whether they live uptown, downtown, or in between, it's common to everybody. And management of stress is a part of the whole mental well-being of the patients. And I know that over the years, doctors would have been encouraged to look at the mental assessment of patients as part of their routine management of the patients. Emphasis on community engagement, we can't underscore that enough. There needs to be collaboration with the communities to design culturally relevant health initiatives. It must be something that they are willing to embrace. If not, you are going to waste your time. You go there, someone they listen to you, and some of them you are there talking, and they close their ears, and they see your mouth going up and down like this, and they're not hearing a thing because they have closed their ears. And so we need to plan with the people, for the people. And in doing that planning, we are going to be now using a participatory approach to ensure that inclusivity and equity is on the board. When we look at integration of technology, we want to have leverage with the digital health tools like mobile apps, telemedicine, and wearable devices. So we know there are some wearable devices that persons who have been buying on Amazon or other platform, and they are using those. The mobile apps are there. Telemedicine seems to be getting traction these days. And I know that some of our health facilities do some telemedicine. I think like Bustamante Hospital, they have, I think it's every Thursday afternoon, they do telemedicine where they connect with some of the experts from abroad, and they do case study discussion so that the management of the patient can be as optimal as possible. The mobile apps are there, we know that some of those. And with COVID-19 telemedicine too, we're now at the place where a doctor can call in a prescription and you can go pick up your medication at the pharmacy rather than having to wait to go in and get the paper and go in. So we are making some strides. Granted, they are sometimes slow, but we are making some headway where that is concerned. And we have wearable devices or things like pacemakers that can be implanted to help with the whole business of the function of the heart for persons who have cardiovascular issues. Using social media platform for health education campaign, we have to look at how we can engage our audience on these platforms because that is where they're at. So we need to meet them and we need to know which age group is where. So we know that the old people them is where? Facebook, and when the young people them there? Instagram and TikTok now is a mixture of everybody. The young and the old and in between is on TikTok. You know what it is about TikTok, but they're on TikTok. Strengthening the system, we'll talk about training for healthcare providers to prioritize preventive care and to address gaps in health infrastructure and the services. And when it comes to the whole business of the behavioral strategies, we really want to use evidence-based approach like nudging, peer influence, and incentive programs. And we encourage long-term lifestyle changes through education and provide a supportive environment. What time do we have time for this class activity? What time is it? Oh, okay. All right. So you're going to be taking on this. And you need to try and see if you can do that. Share ways in which you think renewed health promotion strategies may be incorporated into management decisions and our programs to enhance health. Any suggestion? You can do it as a whole class. You see where health promotion can enhance what you are currently doing.
Yes. Cooperate. If they buy in, like in the health relief model, and see that it's important to them, then it'll be easier for us when we come. Especially like things, simple things like getting 2 blood donors, no matter how much we chat in the health sector and at clinics, please get your 2 blood donors. Everyone comes without any blood donor, the age of 7 and 8. And then they encourage us when they can't get their surgery because there's no blood in the blood bank to be reserved or prepared for them. So we try and educate them on how important it is to have these blood donors and the risk, because every single delivery, anything can happen. So that's just like that.
Okay. You can think of other examples as well. So renewed strategies for health promotion, re-energize key health settings, ensure that community participation and empowerment and civil society is engaged, enhance good governance, and this is like a summary of what we have discussed. Enhance good governance and intersectoral work and address the social determinants of health. Look at how we can strengthen the health system as well as the services that are offered to health promotion. When you look at other actions for renewed health promotion, policy advocacy is one we can look at. We need to support the laws and the regulations that encourage healthy living, such as smoke-free zones, reduce sugar content in products, and herbal planning for active lifestyles. And when we're doing even the reducing sugar content in products, we have to engage other sectors like Arada, who can teach persons how to bake their cake minus sugar. And sugar-free cakes don't taste fresh. And that's what some people don't understand. Right, and like raisins. What?
What do you use for the sugar? Do they use like sugar alternatives?
No, simply no sugar in it.
Like banana.
And some of the ingredients are already sweet. They do have some amount of sugar. So you do find even some bakeries now when it comes to Christmas. And so they talk about the sugar-free cake or the sugar-free bun. And I tell you, they don't have hands to sell the sugar-free ones. People just have a way of gravitating towards those. I don't know if it's out of curiosity to see what it tastes like, but those tend to go faster than the other ones. So those are some considerations that you can actually put on the table. When it comes to public education, you launch new campaigns focusing on emerging health issues like climate-related illnesses, digital addiction, or food sustainability, capacity building. We look at the training of our leaders and volunteers to serve as health ambassadors in their communities. And the Jamaica Moves in School was one such example that we can draw on, where we did train ambassadors within the schools. We had 2 teachers from each school and 4 students, and they were the health ambassadors, and they went back. They had their healthy lifestyle clubs that were formed, and they were doing a lot of activities. Trust me, it was heartening to see that they bought into it and they were just running with it. Resource allocation, direct your resources to the underserved population to reduce their health disparities. And I think the government is really doing some of this with the National Health Insurance and putting onto the health insurance a lot of the VEN list drugs, so that when they go to access those, the amount of money from their pocket is really very, very minimal. So some of this is being done to help to reduce the disparities. But when you come to the hospitalization, some of the surgeries too, or some of the diagnostic assessment, persons are still being asked in many regards to go outside, source that service and bring the information back to them. So we have started the process, but we still have a long way to go. Research and innovations, invest in understanding the current health trends and their solutions and adapting them to diverse populations. So for everybody who passed through this program, have been exposed to doing some research that can help to guide policy and intervention programs. So in summarizing, renewal and health promotion is needed for a number of reasons to include inequities in the health system, social determinants of health that are responsible for much of the ill health that is being experienced by our population. Health promotion has been found to be able to positively impact the social determinants of health, and we need to identify the threats to renewal of health promotion and devise strategies that can be used to minimize them. The renewal of health promotion is a strategic movement to revitalize the values, the relevance, and the impact of health promotion in ever-changing world. And for the Caribbean, it represents the recommitment to the principles of the Caribbean Charter of 1993, where they had focused on empowerment, equity, participation, as well as intersectoral collaborations. And while we are doing all of that, we have to look at the modernization of today's realities, where we are looking at digital health, social justice, and the whole business of the sustainable development goals. So we need to identify the strengths, such as the improvements in communication and the support that we get from our partners, such as PAHO, and we still have PAHO and WHO on board, really partnering with us. We also have UNESCO and UNICEF. They are still a part of the international partnership that we do have access to. And there are currently 4 strategies to renew health promotion. I would have gone through those already. The re-energize the healthy settings, community participation and empowerment, better governance, and the strengthening of the healthcare system. And so in closing, this is your nugget for today, that faith doesn't always take you out of the problem, but faith takes you through the problem. Faith doesn't always take away the pain, but faith gives you the ability to handle that pain. And faith doesn't always take you out of the storm. What faith will do, it will keep you calm in the midst of the storm. And those are my few words for this afternoon.
Amen.
All right. And amen. And you would have already gotten the information, I think, in terms of the relook to the qualitative research.
Yes, the good news.
Yes. We aim to please, you know. And we are really very careful about your mental health.
Yes. I appreciate it.
So having said all of that.
But the checklist is still tomorrow.
If what?
The checklist is still tomorrow.
It would be good if you can do that, because it would give us a chance now to go through that checklist. And there needs to be any correction for modification, then you can get that prior to going out on the road. So it really would be good if you could submit those.
Okay.
All right. So have a great rest of the day, everybody.
You too, miss. Thank you.
Thank you. Take care.
right, good afternoon, everyone. All right, so we are going to talk about cohort studies today and the related measures of association to conclude your EP1 finally. So basically, we'll just be reviewing the elements of cohort studies. We want to discuss the measures of disease association associated with cohort studies. And then we're going to discuss bias, chance, and confounding relating to whatever risk estimate. I think they're up here. So you would recall that we've gone through the observational studies. Just a reminder, we spoke about our descriptive studies, such as our case report, or case series, or ecological studies, and we also included in that cross-sectional studies. But we also spoke about our analytical studies with respect to outcome exposure relationship, and we've covered cross-sectional study, a case control study, which we did the last time we met. And so today we will be talking about cohort study. And as we get to EP2, we'll cover the other aspect which speaks to experimental studies. Just a reminder as well, in terms of the level of evidence, that at the base, you would have your expert opinion, you have your case report, case series, your cross-sectional, your case control. So this is where we are now looking at our cohort study. So with analytical epidemiology, as we know, the emphasis is on confirming and refuting hypotheses, establishing cause or assessing the effects of intervention. And specifically, where we speak about establishing cause, we know that the Bradford-Hill criteria for causation basically outlines various criteria to meet if we want to determine cause. And a lot of them, a lot of what we have here as criteria, they've been criticized. And so lots of people really go with the whole issue of temporality. So in a cohort study, of course, strength of association is a very key one that will come about when we look at our cohort study, when we're doing the measures of associations. But of course, temporality, which speaks to the fact that the exposure should precede the outcome, is a big one that a lot of epidemiologists would believe that, you know, it matters. So in a cohort study, it's basically undertaken to support the existence of an association between suspected cause and the disease. So it is a study in which individuals are selected and grouped based on their exposure status. At the time of the exposure status, the potential subjects are free from the disease or outcome under investigation. And the subjects are followed over a period of time to determine if they develop the disease or the outcome. So this is what the design looks like. We have our subjects. We break them up into exposed or unexposed group, and our unexposed group can be our control, our comparison, or reference groups. And then we're tracking them over time to see whether or not they develop an outcome. So if the outcome is disease, whether they develop the disease or not, if they're among the exposed group, or among the unexposed group, if they got the disease or not. We contrast that to a case control study where we know that the enrollment is basically based on outcome status. So those with the outcomes are categorized, or the outcome is categorized into the case group, and then those without the outcome, we call them our controls, and then we're trying to determine their exposure status. So we have two main types of cohort studies. We have the prospective cohort study and we have our retrospective cohort study. So with the prospective cohort study, the exposure may or may not have occurred at the time when the study is initiated, but the outcome for sure has not, or outcomes have not yet occurred. While with a retrospective cohort study, both the exposure and the disease or outcome have already occurred at the time when the study is initiated. So if you recall, for those who would have been familiar with this example, so in 1967, we initiated a study to assess the association between asbestos exposure and lung cancer deaths in the US and Canada. So our exposed group, 17,800 male asbestos workers, and then the unexposed group, the general population of males the same age. And then we want to look now at the outcome, which is lung cancer, to see whether or not deaths occurred between 1967 and 1975. So we're starting the study in 1967. We enroll based on exposed versus non-exposed status, and then we're following people to see if they develop the outcome. That is what characterizes a prospective cohort study. But like I said, sometimes when we're doing a prospective cohort study, the exposure may or may not have occurred at the beginning of the study. So sometimes people may have an interest in studying a cohort of people. So in this example, they're studying a cohort of 117,000 nurses. The outcome of interest, cancer or cardiovascular disease. So at enrollment, they just want to know that they are free of the outcome of interest or outcomes, cancer, and then cardiovascular diseases. So what would happen? You want to, as time goes by, you put people in the group. So it could be at the start of the study, but later down, you might do an assessment for a particular thing and then categorize people. So at the start of your study, everybody may not be exposed. And so sometimes as well, you may have to, when you continue, you may have to change your exposure status based on what, because if you're following people over a long time, people's exposure may change over time. And so you will need to take that into account. So it may just be like, for example, you could enroll a birth cohort, so all babies born in this year, right? And along the way, you try to do whatever test you're doing to categorize them as exposed or unexposed, and then you follow them to see if they develop an outcome of interest. The important thing is, at the beginning of your study, they should not have the outcome of interest, all right? And the beautiful thing about this, or following a cohort, is that when you do the assessments, you know exactly when their exposure would have begun, right? So you account for all those times. With a retrospective cohort study, remember now both the exposure and the outcome would have occurred at the beginning of the study. So in 1965, we decided that we want to conduct a study to assess the association between asbestos exposure and the lung cancer. So our exposed group would have been those working at those asbestos workers from 1948 to 1951. And then now we choose our unexposed group, which would be cotton textile workers from 1948 to 1951. And then what we are trying to ascertain is whether they had lung cancer deaths from between 1948 and 1963. But you realize when we started the study, 1965. So both the exposure and the outcome would have occurred before the start of the study. So as you can well imagine, that what we're going to have to rely on is secondary data sources for most of the information that we're going to gather. So for example, we may have to use HR records to see who would have worked in the asbestos industry at the time, and then for those who would work in cotton textile industry, and then we're probably using cancer registry medical records to determine lung cancer deaths, all right? And this is just another depiction, but just recall that both the outcome and the exposure would have already occurred. It doesn't change the fact that in a retrospective cohort study, we're still starting by enrolling the people based on their exposure status. What is also going to be important though is that we would need to ascertain that these people, based on whatever registry or information, medical records, that they would have been, well, clearly they would not have died, right? But whatever the outcome is, they would be free of the outcome at the start of this, when you, in terms of when you want to enroll them, right? Now, there are certain issues in terms of the design of cohort studies that we have to look out for. So the selection of the subjects, we're gonna get the exposure and outcome data. The approach is to follow up the data presentation and analysis, and then the interpretation of results. So with the selection of our study population, we want to create our study population. We need to clearly outline what the inclusion and exclusion criteria are. So we're enrolling based on exposure status. So how do we determine who's exposed? How do we determine who's not exposed? We need to clearly define how we're going to determine that. So it depends on the hypotheses on the study and the feasibility considerations. So for example, occupational groups, groups undergoing particular medical treatment, professional groups, geographically defined area may constitute what we call our exposed group or an unexposed group, depending. And sometimes you may need to assemble a special cohort. So if the exposure is common, you may want to use a cohort that will facilitate accurate and complete ascertainment of the data. For the unexposed group, the choice of an appropriate unexposed group is also very important, although it's not very easy. So the comparison group should be similar as possible to the exposed group, except that they don't have the exposure. You can use internal comparisons. So selected from the same study population as the exposed group, or it could be external, meaning from another population, or you could do the general population. So your occupational groups undergoing a particular medical treatment, certain professional groups, geographically defined areas could also be used as your exposed, your unexposed group. And you could get your exposure data from pre-existing records, questionnaires, interviews, direct physical exam or test, and your environmental monitoring data. Of course, you have many other things. For your source of your outcome data, depending on what it is, you could get it from death certificates, cancer registrations, health insurance claims, medical records, questionnaires, interviews, direct physical exams or tests. And then a big thing in cohort studies is the whole approach to your follow-up. So in any cohort study, the ascertainment of outcome data involves tracing and following up people. So what you want to do is to try to minimize the proportion of subjects that are lost to follow up, right? Because if you have people dropping out, you don't know if the people who remain are similar to the ones who drop out. So it becomes an issue. And some resources you may need to conduct your follow-up. You need your census list, telephone books, if you still have them, or your Yellow Pages online, or whatever you use. I don't even know, do we still have phone books? Do we still have house phones?
Yeah.
I legit have a house phone. What's the number? I don't know. I don't know. I don't know if it has ever run, because it's digital house phone that I have, not flow phone anymore. I just don't know. I don't even know if it works, you know. I actually don't. And then it's so dependent on the electricity. So there's no electricity, there's no phone. Gone are the days, and you know, the electricity is gone and you still have your phone line going. That's not the case anymore. You may have to depend on relatives and friends, birth, death, or marriage record, physician or hospital record, or the security personnel. All right. So the next thing we're going to discuss is the whole issue of analysis, which is going to now be a big thing. So if you recall, and you're very familiar with these things, having done your brain joggers so nicely, right? But everybody got the formula right, so I'm okay. At the very least, we need to recall, you know, how to calculate prevalence, which is the number of existing cases over the total population at a particular point in time. The cumulative incidence, which refers to the number of new cases over the population at risk, And then our incidence rate, which is the number of new cases over the person time at risk. And since you're so good at it, I want you to calculate the cumulative incidence and the incidence rate for this study. Let me move this thing so you can see properly while I grab some water. So we're calculating cumulative incidence rate quickly. All right, who's ready to answer? So what is the cumulative incidence? So it's number of new cases, population at risk. So what's that? This is the part that I get no grade for, you know, the formula. You don't get so let me get the numbers now. Guys, today, you know. That's what I put in here, number wise. Get the pen. Oh my. Ready?
Yes, May. So it's 3 number of new cases, 3 over population at risk, 12 of them, based on this thing here. So that's 0.25, 25 cases per 100 population or something like that.
And it's over what time period?
That's a good question. A few years.
Death. Over
14 years.
Okay.
Yes,
So
thank
that
you,
means
Nicole.
so that means what if we want to get the cumulative incidents per year on average, we would divide by 14. Right? What would that be? Do I need to go for a calculator for myself? Huh?
0.0325.
0. What?
3.
I didn't get 3, I got
0.03?
0.017. It's 0.25 divided by 14.
Yes.
0.01178
Yeah,
or
0.0178.
179, because there's a 5 there. So we're going to round up 179.
All right.
So why would divide by
Oh, I see.
14? That part that miss me.
This is no, so you're calculating the cumulative incident for 14 years.
The
So it's either you're
0.25
gonna
is
say-
for 1 year.
The
No, you're
0.25
looking
is
at
for the
all
full 14 years.
14
years.
from
Right. So if you wanted
1980 to
to know it for 1
1994.
year, then you'd have to divide by
Divided by
14.
14
If we divide by the 14, we get what, per year?
per year.
Yeah.
Ah, got you.
And then and why I did that, because we could have done it afterwards, but for the incident rate, it's 3 over what?
100.
See, guys?
It's
Right, so that's
100.
equal to what?
0.03.
And so
person
the-
years.
and so you- Right, so it would be cases, right? So it would be cases
Cases.
for whatever is the multiplier, years, right? So if we're using 1.79 and then we would have 3, 1.79 cases per 100 population at risk. And then we have 3 cases per 100 population per year. And it's population at risk per year. Because the person years take it down to years. So if you want to compare them, then that's why we divide for the 14 years. All right? Okay.
Muddy but clear.
So do we divide the
Right.
0.03 by 14 too?
No, because this now is giving a person years, a person per year.
Oh, okay.
Right, that is what person years basically will break it down to. Well, this is over 14 years. So Nicole, since it's muddy, I'll give you another one. Right? So the only correction to this is that this time period, there's one time period that's wrong. So from January to January is 2 years. From July to July, here's 5 years. This is from July to January, so this should be 3.5 years. For subject D. So that in essence, high is 16. Yeah, man, so that's why you should just tell me quickly, what's the answer? the cumulative incidence is going to be what?
2 out
How
of
many new
5.
cases? 2 out of 5 over 5 years, right? And the incidence rate is 2 out of what? 16.0. So what is 2 divided by 5?
0.4,
Divided by 5 years,
0.08.
which is 8 per 8 cases per 100 population at risk per year. And then for the incidence, 2 divided by 16.
This example looks
1.25.
familiar. Let's do the example here some time ago.
Yeah.
Okay.
wait.
All right. So remember how to calculate cumulative incidence and incidence rate. Yay. All right, done. So in our analysis, what we aim to do is to always try to work out try to determine the incidence rate in the exposed group and then in the non-exposed group. And for cohort studies, what we're trying to do is to estimate risk, right? So we are estimating the risk of developing an outcome, right? So when you do incident, you're really trying to determine people's risk. So for the cohort study, we would calculate a relative risk, an attributable risk, and attributable risk fraction. So we've already reminded ourselves how to calculate incidence rates. So in the design of a cohort study, we know that first we identify the exposed, then you identify the non-exposed people, then you follow them to see whether they develop the disease and who doesn't develop the disease. And we end up with our characteristic 2x2 table. So we have those exposed, those not exposed, those developing disease, those not developing disease, and we have our totals. So when we're working or presenting our data, when we have information on cumulative incidence, meaning the data is number of cases, right, over the population at risk, so raw numbers, right? So this is not a case where we have person time at risk. This is just raw numbers. What we would do is set up our table in such a way to reflect the actual numbers in each category, and then we have our totals. So in this case, it is a cohort study of oral contraceptive use and bacteriuria among women aged 16 to 49 years, and this is a 1-year study. So in this case, we have 2,390 women, 16 to 49. Oral contraceptive use is our exposure, bacteriuria is our outcome. What is the prevalence of bacteriuria in this study? What is the prevalence of bacteriuria in this study? Prevalence is what? 104.
Existing cases, 104 over
the total.
Right.
And that is what? We need calculators for this session. Okay, please take them out, okay?
Total is what, 2390? Get my calculator, 1 second.
I'm getting
Please,
0.0435.
What is it?
4.35%. I
correct?
taken the 104 divided by 2390.
Yeah, that's
So that's
4.35%. 4.35%.
All right. So we, from cohort studies, will determine a relative risk. And that is basically
Sorry,
the
what was
probability
the
of an
answer,
event.
please? I missed that.
4.4, Auntie Vanessa. Because you went for a calculator. Such a good girl.
How we get 4.4?
Percent?
The 104 over the.
Oh, percent.
Yeah.
Okay.
Mhm.
Oh, okay. All right, so we take, all right, yes.
All right, so we determine a relative. So the measure of association, right? Remember, we said when we do a cohort study, we're trying to determine the strength of an association. So that measure to determine if one variable is associated with the other, this is called a relative risk. And so a relative risk is the probability of an event developing a disease occurring in the exposed people compared to the probability of it occurring in the unexposed. So it's really a ratio of two probabilities. And it's important for us to use that to measure the strength of association. So if the relative risk is equal to 1, it means that the risk in the exposed group is equal to the risk in the non-exposed group. No difference in risk. If it is greater than 1, it means that the risk in the exposed group is greater than the risk in the unexposed group. And with that, we call it a positive association. And, it's possibly causal, possibly. We know that causation thing is problematic. And then if the relative risk is less than 1, it means that the risk in the exposed is less than the risk in the non-exposed. And that's a negative association and it's possibly protective, all right? I'm sure I deleted a lot of these things from your paper, but never deleted it from my teaching, notwithstanding. So to calculate a relative risk, we work out the cumulative incidence in the exposed versus the cumulative incidence in the unexposed, right? And so the cumulative incidence in the exposed, if we look back on this, is what? This is the cumulative incidence among the exposed group.
Well, the number of cases would be 27. And the total population at risk would be 482.
And then what is the cumulative incidence in the unexposed group? 77 divided by 1908. And so when we calculate that using the numbers as we have them, what we get is 1.4. So who's gonna give me the interpretation of this? So there's a
The
positive
relative
association.
risk.
Wouldn't it be like persons who took OCPs had 1 point or were 1.4 times more likely to also have bacteriuria as opposed to persons who didn't?
Not also, like to have. You just need to cross out the also, so start again.
So persons who took OCPs were 1.4 times more likely to have bacteriuria than those who didn't.
Yeah, that's it.
Do you just say
Yeah.
that, or do you say the relative risk? Or
No,
that's
you don't use but the
okay.
relative risk. You need to actually interpret the actual
Oh.
value.
Okay. Okay, thank you.
So persons who took oral contraceptives are 1.4 times more likely to develop the outcome, which is bacteriuria, than those who didn't, because they're the comparison.
So this is straightforward.
This is the very straightforward one. It's not like we're doing odds. Alright, so this is very straightforward indeed. Which is why I prefer to teach it first to get that direction.
So if we were, let's say, 0.4, let's say,
Or we're getting to it. I'm giving it that one, you know.
Okay.
So say we change around the numbers in the table. And we had 77 people being exposed who developed bacteriuria. And the total in that group was 1908, and then we switch it around. So in this case, where we calculated the relative risk, it worked out to 0.714, right? So how would we interpret that? So what you're saying, Alex, is the difference from 1?
Just a thought. So instead of saying so person, so the initial
Key?
concept of person.
No? Marlene? Marlene? You guys hear me? Oh, I have my key. Oh, sorry. Alice, can you grab it one past my calculator on it? This is the key for the my door, and the front one is locked. Wanna say, what this now? What's the interpretation? Don't say too early. Yes, I too early in the show. What that big say? Huh? All right, so we know that them the less likely what one is a number game we play now.
That would be the exact number is 28.6% less.
Less likely, right? So remember, if the value goes below 1, we can say as likely in this scenario. So we could say you're 0.714 times as likely to develop bacteria if you took oral contraceptives versus if you didn't. But that's not so intuitive for people. So typically what we do is subtract that value that's lower than 1 from 1 and report it as a percentage. So that would be, so we would say 28.6%. So in essence, we're saying those who took oral contraceptives were 28.6% less likely to develop bacteriuria compared to those who did not take oral contraceptives. Good?
Mm-hmm.
You guys leaving?
No, not good. Yes.
Who not good? What is it?
Okay, so why are we taking it from 1?
Because you can't say 0.74 times less likely because it's really not it's not 0.74 times less likely. Because if you look at a number line and this is 1, which is the point of no effect, and you get 0.714. This is not 0.714 less likely because the reference point is 1. So the distance between this and this is really 0.286, which is 28.6% less likely.
Okay.
So the general rule of thumb is 1 minus the calculated value and you report it as a percentage.
But we didn't do that before.
No, this is
You
because
didn't need
it's
to because it was over 1. So over 1, you just report the actual value, 1.4 times more likely. It would be 40%.
It was exactly 1.
Huh?
It was exactly 1.
There is no difference. It means that the risk in the group, in the oral contraceptive group, for developing bacteria is the same. All right. And so you can, if it is greater than 1, it can report as a percentage. But just that when people reach 2, then it becomes a little tricky because you need to now remember it is 100 and something % more. So you just report it as the number. But if you report it as a percentage, you're not wrong. Providing that you're going to do it correctly. Right, which in essence, it would be 1 minus the calculated value minus 1. Right, so 1.4 minus 1, you get 0.4, you report that as 40%. All right, 5.3 minus 1, and you report as 430%, which is, thank you very much. So it does report the number to say that it is more likely, 5.3 times more likely, 1.44 times more likely. But once you go under 1, then you say 1 minus the percentage and report it as a percentage less likely. All right, so that's the relative risk. So we got relative risk, and that's really trying to measure the strength of association. So if you had done or calculated relative risk and you get 3.5 or 6.7, you know, the bigger the value, the stronger the strength of association. That's really what it's saying. All right. So attributable risk is another measure that we use, and it's basically trying to determine how much of the outcome can be attributable to a particular risk. So it's really estimating the excess risk of the exposure, right? So if you're exposed, what is that excess risk? Because at baseline, we may all have the same risk, but the exposure may add a greater risk. So we're looking for excess risk when we're calculating attributable risk. So it is a valuable measure since it provides the estimate of the relative impact of the poor outcome that could be achieved if the risk factor were eliminated or reduced. So the interpretation of the attributable risk is dependent on the assumption that there is a cause-effect relationship between the exposure and the outcome. So that is something that we're assuming. Because when we say that something is attributable to something, we're in essence saying, okay, we're assuming that this may cause it. It's an assumption that we make, all right? So in essence, it's how much of a disease can be attributed to a certain exposure. So how much cancer is experienced by smokers can be attributed to smoking. It's the risk difference or the excess risk. And while we look at the relative risk in terms of etiological relationships, when we look at attributable risk, it's really important in clinical practice and public health because we use it to drive prevention programs. So if we see that you have excess risk from an exposure, if we take away the exposure, you know, how much of the outcome are we taking away? So we use it to help with the control. So what we're basically determining, because if you look at risk levels, at baseline, everybody's gonna have a particular risk, right? But if you're exposed, that exposure could add further risk, right? And that is what we call the attributable risk. So just to note that when you're calculating excess risk, as you can imagine, the relative risk would have to be over 1, meaning it's a positive association. You're more likely to get something if you're exposed. And so if the relative risk is not over 1, then you don't need to calculate an attributable risk because there is no excess risk, all right? So in this case, the attributable risk, which is determined from the cumulative incidence in the exposed minus the cumulative incidence in the unexposed. So we've already worked out the cumulative incidence in the exposed and the cumulative incidence in the unexposed, right? So what we've gotten is 0.016 as the calculated value. What does that mean? Who wants to guess? It's not guess. Say that again.
There is increase of negative bacterial increased by 0.016 if you took the one. Okay.
So as you can see, remember, so but you can't hear. Everybody's hearing me? Daniel can't hear.
No, hearing you, but I couldn't hear what the person was saying.
Okay. What I was saying is that we need to interpret it. Remember now, this is attributable risk. So our calculated value was 0.016, which we're saying that 16 cases per 1,000 population per year, per population at risk, because we know that's what we're talking about, right? So how would we interpret that? So I put it in the brackets as a guide. Huh? And the number we are dealing with. So the interpretation reach, so we are dealing with the number. And I'm giving you this to interpret. So you calculate
But
this
there
and
are 16 per 1,000 cases per year.
Of what? So 16 cases
Additional
of,
cases.
or so 16 cases of bacteria per 1,000 population per year can be attributed
to
the use of
OCP
oral
use,
contraceptives.
OCU.
So alternatively, you could eliminate, remember we said we're assuming there's a cause-effect relationship. So alternatively, we could eliminate 16 cases per 1,000 population at risk per year, 16 cases of bacteriuria per 1,000 population per year if oral contraceptive was not used, right? Or if we got rid of it, whatever you want to say, right? So two interpretations that you can use. So, or right, oral contraceptive.
Or we can have 16 less cases per
Per 1,000 population, right?
per year.
If no oral contraceptive was used.
And so, Miss,
Okay.
Yes, ma'am.
this kind of phrasing can only be used for attributable risk.
No, answer it again.
In saying, in the interpretation, in saying that we would have 16 less cases. Can we, is this interpretation, this form can only be used for attributable risk?
Yeah, the attributable risk is what we're determining. Yeah. There is no formula sheet. Let me scream it. There is no formula sheet, okay? You have to remember them, but get the concepts.
So for the attributable risk, it only works one way when there is when there's a positive
Excess risk, when the relative risk over 1.
Okay.
So if there's no excess risk, you can't calculate an attributable risk. It's called risk difference, excess risk. So if we say excess or difference, you have a minus, okay? Concept 1, cemented in your head. You don't need the formula sheet, you get it already? You got it.
You have to remember the formula. So even though we understand it.
Guys, I believe in you. Every year, let me tell you something. Let me tell you something. That's why remember the concept.
All of the formulas are the
Right. So one,
No, but they're close together, like, I can calculate the other one for this and the other one for that.
No, do that. Trust me. After years of experience, I know that you guys will get it, as everybody else have gotten it, you know?
That was 3 minutes up.
Huh?
This might be the year that surprises me.
No, not surprise me. I'm guaranteed. I can guarantee you that you will not surprise me. And me say all 1 year people cuss me off, you know, like good cuss off. Me disgusting, me wicked, and all. So is that serious? Yeah. just so you know,
Disgusting. What?
My heart is black. All right, because you know, no formula sheet, but trust me, it's something. Listen, it's not a lot. Conceptual.
It's a lot.
I feel like we're not cutting off same way. I feel like it's a little cut off for you. It does not matter. I'm saying. However, I've experienced many groups. Probably 9 is my 9th group, and despite the fuss, everybody holy practice on a good road.
Like, are there any other formulas to memorize?
This is the end of guys. Nobody not tell you if you're gonna memorize that. All right.
So,
Come on, ones. Let us. So, do we understand the concept of accessories? Yes. Right. Listen. You see all of this conceptually, you get it. You're good.
We're gonna review session first.
I will.
Okay.
But you want to talk about reviews. Listen, I also will only have the review session after you guys have reviewed, because if me come in here and come tell you about attributable risk when you're not study it.
You can have practice people like 5 stars that
How you can get all the past levels of the prior year? I don't
you like to give that to me?
know. Miss Candy just ask her to say whatever it is. Whatever she does. Okay, we don't. I mean, it's you practice, but you can practice and it don't come to, so you know. That's a whole different ball game. And then, you know, and so this is where the course out comes to say, imagine, or also you make me go practice them here and them not come like, okay.
What is the attributable?
So I gave you two things before. Relative risk, remember how to calculate it. So remember ratio of 2 probabilities, so you can have cumulative incidence in the exposed minus divided by the cumulative incidence in the unexposed. Get the relative risk. We know how to interpret it if it's over 1, if it's under 1, if it's equal to 1. The attributable risk is the excess risk or the risk difference. Is the cumulative incidence in the exposed minus the cumulative incidence in the unexposed. Good?
Is there a case where the data in the reverse where it's the exposure decreases the risk?
Yes, and I'm coming to that. So an attributable risk percent or fraction now is the percentage of the incidence of the disease in the exposed, that is due to the exposure. So it's a percentage of the incidence of the disease in the exposed that would be eliminated if the exposure were eliminated. So when you look at attributable risk versus attributable risk fraction, so the attributable risk is an absolute measure. So it's looking at the number or the rate of cases that are due to the exposure. And then with the attributable risk fraction, it's a relative thing or a proportional, and it's really the proportion of cases among the exposed that's due to the exposure. How is it calculated? So it's really the cumulative incidence in the exposed minus the cumulative. That's right. Minus the cumulative incidence in the unexposed over the cumulative incidence in the exposed, right? So is there a calculation on your paper for this? Yes or no? Yes? Okay. It's probably there with the interpretation as well. So we did already calculate the cumulative incidence in the exposed and the unexposed. As you will recognize, the attributable risk is at the top, right? And so to get a fraction, we're looking at the cumulative incidence in the exposed. So cumulative incidence in the exposed minus the cumulative incidence in the unexposed over the cumulative incidence in the exposed, and then we report it as a percentage, so 28%. And remember now we're looking at the proportion in the exposed group, right? This proportion of the outcome in the exposed group that's due to the exposure, right? So how we would interpret that is among those with oral contraceptive use, because we're specifically looking at the exposed group. So among those with oral contraceptive use, 28% of bacteriuria can be attributed to the oral contraceptive use. Or we could say if oral contraceptive use were completely eliminated, it is estimated that 28% of bacteriuria cases among oral contraceptive users could be prevented. And remember, always you're assuming that the association is causal. Let me show you something quickly before.
Those two statements sound so like,
It's so
one sound like full marks and one sound like.
it's the same mark. So when we look at attributable risk, we're looking at what is the risk difference. So compared, so remember now that if you're unexposed, this is the baseline risk, right? So when you look at attributable risk, the excess risk, this is what we're trying to determine. That the exposure would add this excess risk. When we're trying to calculate the attributable risk fraction or percentage, we're saying this proportion is what we're trying to calculate. So as a percentage, so among the exposed, what percentage of the outcome can be attributed to the exposure, which is the oral contraceptive use. We're looking at it relative to the exposure among those exposed, right? So this is what we're calculating, right? So this is it. Among those with oral contraceptive use, 28% of the bacteria can be attributed to the oral contraceptive use. An important thing is what we're looking at, if you see the denominator, among those with the exposure. It's among those with the oral contraceptive use. They are the ones we're looking at when we talk about the attributable risk percentage or fraction. All right. Sometimes when you get or do your relative risk calculation and it's below 1, people like to know what they can do with that in terms of working through programs and all of that. So there is this analog measure if the attributable risk is, sorry, if the relative risk is under 1, right? Because if the relative risk is over 1, we calculate the attributable risk. If it's under 1, you can do the attributable risk. So this analog measure, which is called a preventive fraction, you can use it. And basically it is calculated by looking at the cumulative incidence in the unexposed group minus the cumulative incidence in the exposed divided by the cumulative incidence in the unexposed. Nobody will ask you to do this, right? This is for knowledge. So if you want to write it just for knowledge, right? And so what you want to do is to try to determine, what does this mean? So you have this negative exposure. So in this case, which it works out to, 83%. So a preventive fraction of 83% would mean that the exposure aspirin use is associated with an 83% reduction in the risk of stroke among those exposed compared to those unexposed, assuming a causal relationship. So you're just using it to help you with, programmatic stuff, but nobody will ask you to calculate this generally, and typically people don't work it out in studies, But I just want you to know that sometimes people use this as an analog to try to justify, introduction of a preventive measure if it is protective. So this is just for knowledge, a preventive fraction. So then we would have done three things. We would have looked at the relative risk, which is defined by the cumulative incidence in the exposed, divided by the cumulative incidence in the unexposed. The attributable risk, which is the risk difference or excess risk, which is the cumulative incidence in the exposed minus the cumulative incidence in the unexposed. And then the attributable risk fraction, the cumulative incidence in the exposed minus the cumulative incidence in the unexposed over the cumulative incidence in the exposed. And so this is really what we went through. We know how to calculate cumulative incidence for an exposed, so we know the formula, new cases over population at risk, right? So we know that. We know the formula for cumulative incidence, the relative risk, which is cumulative incidence in the exposed minus CI in the, divided by cumulative incidence in the unexposed. Here is the CI in the exposed minus the CI in the unexposed. And to get the percentage among those in the exposed group, it's the CI in the exposed minus the CI in the unexposed over the CI in the exposed. So if you want to get this, now you get the rest of the lecture. Good? Kind of, but still, right? No break. Sometimes, if we have now the incidence data, so when we have incidence data, what we have, the person years at risk or person time, whatever it is, but this in this case is person years. Why we leave this blank? Because we really don't care about the numbers in this group because it's meaningless to our calculation. Because how we calculate incidence again, new cases over the person, in this case, person years at risk. So we only need two pieces of information, so this part of the table would not be necessary. All right. So same way, you calculate everything, but just to know that if you're using incidence data instead of a relative risk, it's called a rate ratio because it's a ratio of two rates. Remember now the cumulative incidence is not a true rate. Remember, base principles. So relative risk is when you use the CI data, and a rate ratio is when you use the incidence rate data. Logical, right? Yeah? Jesus, I'm gonna stop once. It's like when I say, oh my, but I can't admit it. They say it is really simple. I just can't admit it. I don't over there and I get it, but I just can't admit it to say, I don't say not going to don't say because I don't get it.
All me know, miss, my love how you believe in a way.
I quite believe in ginger tea, that's how I believe in it, guys.
So they present the data like what it was before and after. So
if you are doing the incidence rate, you have to have person time at risk for your totals.
So those are some keys.
Right. Or I wouldn't do that though. I would give you data. So if I was asking you to calculate, let me see if I have a question. Sorry, let me go to the end of the lecture. So if I was giving a question, as I would give you this, and I give you a table showing that and then I ask you to determine the rate ratio, may I go expect you ever know what to do? While we're at it, let us do it. So in this case, since we're there, right? A table shows the results of a cohort study with a follow-up of 10 years, including numbers of persons, number of cases of lung cancer, and person years of, for people who smoke and do not smoke. I ask you to define the incidence rate. What is the incidence of lung cancer in smokers and non-smokers? What do you understand by the term rate ratio? And then from the information, calculate the rate ratio. Let me just put it up on the spot. I'm all again on 5 minutes to do it. So we're going to work out the incidence rate among smokers and the incident rates among non-smokers. I'll give you a moment to figure it out. So I want you to work out incidence rate for the smokers, incident rate for the non-smokers. Say thanks to Alex for that.
We have this.
Yeah, it's on page 4. What's the page?
Take it out.
Are you copying? You see, when you ask lots of questions in the class, then you get some appropriately to address your questions.
I will wait.
Incidence rate in the exposed and in the unexposed group. And while you're at it, just do a 2 by 2 table, no? Thank you.
What was that, miss, while we're at it was?
Do a 2 by 2 table.
Just say done when you're done. We're done.
We're done? Hmm?
Jeff?
So So we're trying to determine the incidence rate and so we know that the incidence rate is determined by the number of new cases, and the number of new cases would really be the number diagnosed with the disease, which is among smokers, we have 24. And then among the non-smokers, we had 17. We're calculating incidence rate, so we're really only concerned about the person years, right? And then the numbers that were diagnosed. Of course, you would have another part in the table that's blank. All right. Gosh. No. Enter. All right. I mean, if you wanted and you had this information, which you don't need, because if you were asked now to do the relative risk and you wanted to put the wasn't diagnosed, then you could always put it here, but we're not interested in that. You could minus them. So what we have is we're interested in knowing what the incidence is among smokers and what the incidence is among non-smokers. So the incidence among smokers would then be equal to 24 divided by the person years at risk. And then the incidence among non-smokers would be the 17 divided by 2852. And then the rate ratio would be equal to the incidence rate among smokers divided by the incidence rate among non-smokers, and that's 1.583, right? And what's the interpretation?
Smokers are
What shall I need
1.5
it to-
times more likely to develop lung cancer than non-smokers.
Yeah, all right. Back to the lecture. Thanks for the segue.
You go back to the Excel.
Welcome. So the point I was trying to make is I would not have given you a clear-cut table like this. I would give you to choose the relevant information to use so that you can demonstrate. So given that you understand that concept fully now, you could do this in your spare time. Because this is really just looking at smoking and coronary heart disease. It's a cohort study of cigarette smokers and non-smokers and looking at the outcome. So it's the same principle now that you're going to be working out the rate ratio and you're using the incidence related data, all right? So I want you to calculate the attributable risk now, and the attributable risk fraction is the same formula that you would use for cumulative incidence, except now you're using the incidence data, related data. And remember the formula for the
So you're saying
attributable risk?
for this specific question, we should work. Okay.
Yeah, it's the same formula, it's just that instead of saying cumulative incidence, it's gonna be incidence rate. Ready?
Something look wrong from my end.
What is it? What you do, Vanessa?
I'm guessing I figure where you can't work out the AR.
I think I have it, Dr. Thompson. The attributable
why-
risk. Oh, that is not what I got.
It's very wrong. The numbers are wrong in the table. Go on. No, this is not the attributable risk.
Oh, okay.
That's I went to.
I've gotten 10.6 cases per 1,000 person years for the attributable risk. Yes. I'm not sure.
What is
And
84
then
divided by 3,000?
that is 0.028.
Mm-hmm.
And then 87 divided by 5,000 is 0.0174.
And the
Wait,
first one was
question, what we're
0.2
working on?
something?
We're working out incident rate or cumulative incidence?
The attributable risk. So the incidence rate for exposed versus the incident rate for the unexposed, and then you're going to work out the attributable risk.
What type of formula? I thought the formula was massa. Okay, I thought the formula was
Just
cumulative.
remember that when you say rate ratio, you have to use incidence rate. And when you use cumulative risk, you use the cumulative incidence. So that's how I remember it. Rate ratio,
working out
you have to use incidence
attributable
rate.
risk.
Yeah, but you're working out attributable risk using the incident related data, meaning the denominator for your for this incident rate is the person years at risk, because that is what is in the table. That is all I've given to you.
I see where I went wrong. Okay.
Oh, okay, good. So we say we calculate incidents in the expose. So we know that the cumulative incidence in the expose is gonna be 84 divided by 3,000 and 87 divided by 5,000. So we got 84 divided, right? All of that. So that's 0.028 minus 0.0174, and we got 0.011. So that'll be 11 cases per 1,000 person per year at risk. So what is that saying? What is the interpretation on that?
That smoking, we can use cause, or
No,
is that
no. We're interpreting the attributable risk first. So attributable risk is what we're talking about.
Yeah,
The
but you still have,
percentage.
so it's 11 cases per 1,000 year.
11 cases of
More
what?
cases,
Remember now.
more
Of
cases
what?
of
Cases of coronary artery
artery
disease.
can be attributed to smoking, or is
Right. Right. Or I could get rid of 11 cases of coronary heart disease per 1,000 population if we removed, or if we got rid of smoking, that exposure. So the attributable risk fraction, which is determined now by the incidence rate in the exposed minus the incidence rate in the unexposed divided by the incidence in the exposed, we get 0.393, which is 39.3%. And what that means?
So that means that we could reduce the number of cases by 39.3% if we eliminated smoking.
So always remember what are we here? So it is we're looking among the exposed group. So among those exposed,
yes,
right, we could get rid of 39.3% of coronary heart disease if people did not smoke. We're really just looking at among the exposed group for the percentage part. So remember, we're looking among the exposed group. Yes, sir, Alex. Among the exposed. So an important piece for you to remember, it is among the exposed group that we're looking. So among the exposed group, we could get rid of 39.3% of coronary heart disease if people didn't smoke. But it's among the exposed group. All right. And of course, there's another formula, I put it here, that you can use to calculate the attributable risk fraction. But this is easier to remember. Okay. All right. So when we get any estimate of risk, or any of our estimates, or odds ratio, or relative risk, or prevalent odds ratio, or prevalence ratio, usually once you get those results, we want to, of course, consider three things. So we're considering the whole thing of chance, the whole thing of bias, the whole thing of confounding, right? If you want to remember them, you can remember it by BC, those three things, not remember now. We could say before Christ, not bad word, BC, you know, or however you want to remember it, but it's two C's, right? A B and 2 C's, however you want to remember it. But always when you get those estimates, you have to ask yourself some questions. Is this estimate by chance? Is this, are there any biases? Are there any confounders? And so if we want to rule out chance, we have to determine a 95% confidence interval for whatever estimate. So in this case, we would determine the 95% confidence interval for the relative risk, right? So to calculate, and nobody's asking you to do this, this is just showing you that we can calculate the 95% confidence interval. So what you would do is do the natural logs of the relative risk. So, you know, you have a nice scientific calculator, right? You can just do that. Then you calculate the standard error for the natural log of the relative risk, which is equal to 1 divided by A plus 1 divided by C minus that, and you do all of that in the square root, right? And then after you do all of that minus the 1.96, and we know where the 1.96 comes from, considering we're so far ahead in hypothesis testing, the 95% confidence interval and the z-score associated with it, right, is 1.96, right? And then we would find the exponent of all of that to get two numbers for a 95% confidence interval. So what it will give us, so when you do all of this and nobody will ask you to do it, right, is to give us two values for the risk estimate. To say that we're 95% sure that the values will fall between these two numbers, right? As you remember from biostats. So in this case, remember we were looking at the calculation with bacteriuria and oral contraceptive use. Remember it? And when we worked it out, we got relative risk of 1.4. And we said that you are 1.4 times more likely to develop bacteriuria if you use oral contraceptives. And then, so we get this estimate. So we're saying, is this estimate by chance, right? And to answer that question, we find 95% confidence interval. So to do the confidence interval, I showed you the formula, right? So you find the natural logs of the relative risk, which is equal to that. Then you work out the standard error, which work out to this. And then you calculate the 95% confidence interval, and it's a formula, the natural log of the relative risk minus 1.956 times the standard error, which will work out. That's the lower value. What's your mic is open. And then the natural log using to get the upper limit, right? So it's plus or minus 1.96, so you get a range. Then you do the exponent of those two values, and you get two values that we're going to work on now, or work with, which is a 95% confidence interval for this estimate. So our estimate is 1.4, right? And then we're 95% sure that the relative risk would fall between 0.94 and 2.08. So in essence, what we're saying, 1. It includes 1, and so then we would know that this value now is by chance, and it is not statistically significant.
Right.
So what we're saying is that we're 95% sure that the relative risk is negative and positive in essence. So the only way that it would be statistically significant is if two values are in the same direction. Either both values are above 1 or both values are below 1 for whatever estimate you get, right? So if you get, if the confidence, if you had a relative risk of 1.4, or let's use 1.8, and then the 95% confidence interval was 1.2 to 3.1, then this confidence interval, we know that it would be statistically significant because it did not cross the 1.0 mark, right? So if it does not include 1, then it is statistically significant. Alternatively, if we had that value 0.726, I don't remember, 24, I don't remember. And the 95% confidence interval for that was 0.3 to 0.92. Then we know that this is statistically significant because it did not include 1. All right. So once it does not include 1, it is statistically significant. If it includes 1, then we know it's by chance, right? So it is not statistically significant, and it's purely by chance that we got this. So once we get the calculated value, then we would want to know what the 95% confidence interval is for that estimate so that we can rule out chance. All right? Okay. Okay?
No, we're not, but we're going along.
Yes.
Me say the drama, that's all. Right? And like I said, you remember the whole 1 tail, 2 tail story and the corresponding z-score, right? So if it's 2 tail, what it is, 1.96, right? That's what we're using in the formula. And you're familiar with the table. The other thing that we have to look at is the whole thing of selection bias, bias, which includes selection bias, information bias, right? With selection bias, we want to look at how we select the participants in the exposed and the non-exposed group based on some characteristics that may affect the outcome. And then the information bias, now we know it's about quality of information. The loss to follow up, I highlight it, but it's really an example of selection bias. Can't even see this. It's an example of selection bias. And then misclassification bias now is really where you put people in the wrong groups, right? So the information that you're gonna get in terms of your estimates would be erroneous, right? So misclassification relates to information. So it's really putting people in the wrong group. So you're putting people who are exposed in the non-exposed group, so it distorts whatever you're finding.
In this case, miss, they would have balanced out.
Right, and also you're not gonna get valid information because you're putting people where they don't belong. So for example, you categorize somebody in unexposed group when they should have really been in the exposed group. It will affect your estimates.
I don't get the
Similarly
loss
for
to
the
follow.
outcome.
Sorry.
Huh?
I don't get the loss to follow up being
So
that
remember, no, with
selection.
loss to follow, as I would have explained before, you have a group of people following. It's a real thing for cohorts. So they say you're following them for a long time, they have a risk of dropping out of the study. So sometimes the people who drop out of your study could be characteristically different from the people who remain. So if you think about it, if you're doing a study that looks at outcomes or, disease development, so we're looking at a chronic disease, and all of the young people them drop out of your study, and you only have the older people them in the exposed group in your study, it could be giving a picture that, the outcome is heightened. But if you had in that exposed group the younger people, then you would have differential results from a study. So what happened is that sometimes when you have loss to follow up, which generally speaking, the healthier people would usually drop out, because why would you go for a 3-month, 6-month checkup to look for a condition when you feel okay? So sometimes people just lose interest, people don't go back. And so the people who leave the study don't look like the people who remain. So when you're doing your risk estimates, they're very different, meaning you're going to get either, you're going to overestimate the risk, underestimate the risk in the true sample, Because if people had remained, the whole thing would have been different. The whole estimate would have been different. And so in cases like those, because you do expect loss to follow, you always have to prove that the people who remain look like the people who drop out. So you would need to look at the age of the people who dropped out, the gender, and other key characteristics, and then look at those who are in the study and look that they're not statistically different. So sometimes you have to do that kind of analysis at the end or as you go along to prove that they're not very different. And we've had to do that. So we had a study. We had a study that I mean, this was just looking at people who we were looking at validity of a screening measure for dementia. So we're looking at mental status exam, and then we're looking at diagnosis by psychiatrist in terms of using DSM-4 to categorize them as having dementia or not. So when we wrote the paper, 40 people, we started out with 340 and ended up with 300. Never meant anything to us really, because one of the reviewers wrote back to say, we need to do a full-on analysis of the people who dropped out of the study versus who remained. And we had to provide all those details to just demonstrate that they did not statistically differ, because if they did, then it would have been a problem in terms of the rigor of the study and the estimates that we got. Which was, by the way, quite a challenge. It was quite a challenge because it meant that we had to go way back now to look on the tool to kind of get everybody who we knew dropped out of the study. And sometimes that can also be difficult for you with the whole issue of anonymity. But because we had to bring them back for a second thing, which is the diagnosis by the psychiatrist, then we had to get some personal information so we could call them back. That is the only way we could have. But sometimes it's problematic. So confounding is where we're looking at an additional variable which is not on the pathway between the exposure-disease relationship that could influence, right, both the exposure and the outcome. So it would be a risk factor for the disease and also could be associated with the exposure, right? And what a confounder does, it either underestimates or overestimates whatever it is that you're looking at in terms of like the risk, the odds ratio, whatever. And there are various methods by which you control for confounders. We know that randomization is one. Randomization relates to our clinical trials where people are assigned to groups. They're randomized to group, meaning put in groups without knowledge that they're going in the respective treatment or control group. If we know that something is a confounder, so like if we know that smoking is a confounder, we could restrict the people who smoke. So we don't want them in the study. So in our exclusion criteria, smoking would be one. Matching is a technique we use in what study?
Case control.
Case control studies. And what we're doing is matching, enrolling people characteristic for characteristic. So if we match them, say by age, if age is a potential confounder, then once we match age for age, then we know that age should not create a variation. Multivariate analysis is a statistical method by which you control for confounders. So you put all the variables that could potentially confound, and then you will see how each will contribute to the outcome. If independently one thing is associated with the outcome, so we do our logistic regression, which you since you're all you love statistics so much and you're gonna do it in semester 2, you learn a lot about it. And then stratification is that we just break people down in group and then look if there are differences in the risk estimates by group. All right. So we've spoken about 3 things: relative risk or rate ratio, attributable risk, and the attributable risk percent or fraction. And remember how to work through them, right? Right? Remember the formula, so we don't need a formula sheet. It's 3 simple things, you know. Right, Rashina? Right, 3 simple things. So the 4th thing that you'll be required to remember for this is 4 little things. Huh? Right. However, in the case control, the same odds ratio that you learn for that is the same odds ratio that you use and call it a prevalent odds ratio in the case in the cross-sectional study. And in the cross-sectional study, we're looking at a prevalence ratio, the same way you calculate a cumulative incidence. The relative risk in the cohort study is the same way you calculate the prevalence ratio in the cross-sectional study. It's so simple.
So like neonatal, what age group babies are and their birth rates and death rates and
Those things are so intuitive.
so do we have to remember them?
The common ones, just the common. You know them, man. Dr. James told you.
He gave us a booklet.
Nobody not tell him, tell you the common ones. Did he not? I know he did.
How do you know?
I know. He says it every year. Right? So far we spoke about excess risk among whom the disease is attributable to with a particular exposure. However, sometimes we want to know or look at the estimate in terms of the excess risk to a particular population, right? Because while we do our studies, a lot of times we want to know, say, what this risk would be like in the population, right? And so what we do is try to calculate what we call a population attributable risk, right? Same concept, you know, attributable risk, but guess what? It's gonna now be in the population, all right? So this measure helps determine which exposure have the most relevance in the health of a community. It is calculated as the rate of the disease in the population minus the rate of the disease in the unexposed group. So you work it out by the incidence in the total minus the incidence in the unexposed group, right? Or you can work it out by multiplying the attributable risk by the proportion exposed. So 2 ways, either the incidence, the same result you're gonna get. Either the incidence in the total minus the incidence in the unexposed, or attributable risk times the proportion exposed. So you can decide what's easier for you to remember. All right. So in this case, where we're looking at oral contraceptive use, we want to determine what the population attributable risk is. And so the population attributable risk, which is the incidence in the total, so in the total new cases over the total minus the incidence or the cumulative incidence in the unexposed. In this case, it is CI. So this is CI data we're using. All right. So the unexposed. So incidence in the total minus incidence in the unexposed. And when we work it out, we're gonna get 0.032. And then if we do the attributable risk, and we have previously worked out the attributable risk and got 0.016 times the proportion exposed. And the proportion exposed is everybody who say yes to the exposure, which is 482. So it's 482 over the 2390. I'll get the same response, 0.032 is the answer. So that is basically saying 3.2 cases of whatever per 1,000 population at risk per year. So how we interpret that is among women in the population, right? Because it's really in the population. Everything is just adding in the population. 3.2 cases of bacteria per 1,000 women each year are attributable to oral contraceptive use. So if no women use oral contraceptives, the overall population incidence of bacteriuria would be expected to decrease by 3.2 cases per 1,000 population per year. That is really what it is saying. So in essence, say our study findings are representative, our sample size is representative of the population, and we could extrapolate. In our study, this is the attributable risk. But if I am extrapolating it now to the population, and I work out what is called a population attributable risk, and all I'm reporting on is this attributable risk, but knowing the population. That is all. Because when we do a one study, people want to know, okay, so when we take this finding at the level of the Ministry of Health and apply it to the population, what kind of cases am I going to be getting rid of if I put control measures for these things? All right. And then we can also do the a population attributable risk fraction. And it's really the population attributable risk, which is the incidence in the total minus the incidence in unexposed over the incidence in the total. And in this case, we got 7.4%. And what we're saying is 7.4% of all bacteriuria cases in the population are attributable to oral contraceptive use. And the reason why we're saying all is because we're using the total, right? This is now a general rule of thumb. When we're interpreting things that has a denominator, the denominator is serving as a basis for how we're relating our findings. So, which is why in the brain juggles, when people, you know, the denominator is over number of live births. So it must be among whatever the denominator. So whatever you're relating it to the denominator. So you can't say the neonatal, if you're working out neonatal deaths, the rates, and you're going to say 1,000 deaths per whatever population. If live birth is it, live birth is what you're putting at the end. So you always have to contextualize it to whatever is in the denominator. So if you remember in the attributable risk percent, we spoke about what was in the denominator was among the exposed. Here is among the total, so among everybody, right? That is how we're going to relate it now, and not among exposed, because the total is in the denominator. So we could also interpret if no women use oral contraceptives, the overall number of bacteriuria cases in the population. The important thing is we have to state in the population always, because it is called a population attributable risk. It would fall by 7.4%. So that is that. Similarly, you could, if you have this kind of data, then you could actually still work out the population attributable risk and the population attributable risk fraction, because in this case, we're looking at the incidence in the total minus the incidence in the unexposed. And so the incidence in the total here is what? What is the incidence in the total?
171 divided by 8,000.
And then we're minusing 87 over 5,000, right? And then if we're working out the fraction, then we know that that's gonna now go over 171 over 8,000, right? As the population attributable risk fraction. So that's it. The one thing that I wanted to add, so in this situation, when you're using this formula, we calculate the attributable risk times the proportion exposed. When we're doing this, we're using the proportion exposed from our study, right? But say we know the prevalence of the exposure in the population. Suppose cigarette smoking was the exposure. If we knew what it was in the population from a survey that was done on smoking, then we could, in practice, apply that proportion, the prevalence of the exposure in this calculation to have that as more, like if it's a population-based study that they did, we could use it here just so that it can be contextualized more appropriately. All right. So you could actually use that in practice. So that's a lecture on cohort studies. Reasonable? What is a lot? And will not even take 2 hours, you see? Let me ask you two questions, just so we remember. All right, so this is recap. So we know how we structure a cohort study, right? We're enrolling based on what? So
Exposure.
we enroll based on exposure status. So exposed, unexposed. We'll follow to see who will develop the outcome. Right? Or not. And at the beginning of the study, people should be free of the outcome. Right? We have two main types of cohort study. We have a prospective cohort study and we have a retrospective. With a prospective cohort study, we're starting the study today. So today, 2025, and what are we doing? So we enroll based on exposed, unexposed, and then we follow over time in the future to see they develop the outcome. In a retrospective study, both the exposure and the outcome would have already occurred, so that we're in 2025. So we're looking back to see if in 2015, the people who were exposed or not exposed, and then we look from 2015 to 2024, who developed the outcome. If you recall that a lot of this will be relied on secondary data. In a cohort study, we're trying to estimate people's risk of developing an outcome, right? That is why we follow them to see if them have at risk of developing the outcome, right? We calculate typically 2 measures. We can work out the cumulative incidence, which is determined by the new cases over population at risk for time. And then we can calculate the incidence rate, which is equal to the new cases over the person time at risk. The measure of association in a cohort study is called a relative risk or a rate ratio, which is a ratio of 2 probabilities. So it's either the CI in the exposed over the CI in the unexposed, or in the case of the rate ratio, it's the incidence rate in the exposed over the incidence rate in the unexposed. If the relative risk is equal, or the rate ratio is equal to 1, there's no difference in the unexposed group, right? So the unexposed equal the exposed, no greater risk. If the relative risk is greater than 1, it means that the risk in the exposed is greater than the unexposed. And if the relative, right, so it's possible causal or it's a positive association, and relative risk is less than 1, it means that the risk in the exposed is lower than in the unexposed group. If the relative risk is greater than 1, it means that there is excess risk in the groups, in the exposed group, right, compared to the unexposed group. And to determine or calculate the excess risk, we calculate what we call the attributable risk, which is the same thing. And the attributable risk is the CI in the exposed minus the CI in the unexposed. And what we're doing is trying to determine what proportion or what is the, how much of a particular outcome can be attributed to the exposure. In cases where we can calculate the attributable risk fraction or the attributable risk percent. It's really the cumulative incidence in the exposed minus cumulative incidence in the unexposed over the cumulative incidence in the exposed. And what we're looking at is the excess risk or the excess, how much of the outcome we can attribute to the exposure among the exposed, all right? If we get a relative risk that is less than 1, we can work out what we call a preventive fraction. And this is just FYI. Sometimes the data from our study, when we get our estimates, we want to interpret them looking at 3 key things, whether it is by chance, if there's any bias, and we want to look out for confounding. How do we rule out chance? We work out the 95% confidence interval for the rate ratio or the relative risk, right? If the confidence, if it includes 1, it means it's not statistically significant. So it's just by chance, right? It's a chance finding. Bias, we're looking for selection or information bias. And for confounding, we need to look at the possible confounders and then we look at how we can control it. Randomization, restriction, matching, multivariate analysis, stratification, misses. All of those words. If you want to remember research methods. Sometimes we get the finding, but in public health practice, we may want to see how does this attributable risk, how we can apply it to the population. So we can work out the population attributable risk. And the population attributable risk is determined by the cumulative incidence or the incidence in the total minus the cumulative incidence in the unexposed. Alternatively, it is the attributable risk times the proportion that has been exposed or the prevalence of the exposure. And then we can also work out the population attributable risk fraction or percent, which is equal to the CI in the total minus the CI in the unexposed over the CI in the total. And all we're basically trying to say, within the population, we can attribute X percentage of the outcome to the particular exposure. And that's a wrap. So simple. No, this is not, no, everything was my favorite. I say, really? Favorite. 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 Like, the health promotion, something not bother with it. The epic, my thing. Biostats, research, but just not bother carrying to the things that make you want to, you have to reflect and feel and think and it's just to
into the numbers.
get the quick numbers. The other thing that it's too touchy. Don't send outside to that observation and tell me, I'll tell you, so there is a great tree. You don't know, I don't, the sway in the wind that, like, I'm not that girl. I'm not, that's So that's a lecture, and I've left for you to,
Come back to the other slide, I get the
there's nothing you can realize, you can pick up on this journey.
actually, it's a lot.
Like, but what is this?
That's a whole lecture.
Yeah, but I mean, can you even,
Yes, we can.
pick up yourself?
It's literally everything.
Yeah, but I mean, I can't even understand what I have.
Don't worry, you understand.
Research method is bad, very dangerous. What do you mean, Vanessa? Please open your microphone. And let me hear it. Because
Research
don't
method
get
is
it.
bad. Very
What
dangerous.
bad, you mean bad like it, bad like, yeah, this is it, it good?
So scary. Very
What was
dangerous.
scary about research method?
And if
Some of
Melissa
it
saying
talk
that,
about
you must
embrace it.
know.
Huh?
If the big bad Melissa is saying that, then you must know.
It's Vanessa said. But I don't know what she's talking about today, but yeah. So I've left you some questions. Simple things, so you work it through, you calculate cumulative incidence. Then you want to determine the relative risk and interpret it. This is asking to calculate the attributable risk. What does it imply? The 95% CI for the relative risk was 1.56 to 8.5. What conclusion can you make on this piece of information? Say why you have the conclusion. Researcher collected information on potential confounding. So you want to talk about one and then try to see how you would adjust for it. Question 2 was talking about coffee drinking and fetal deaths. It gives you the cohort, so you should say what type it was. Put the table in the information in a 2x2 table, calculate the relative risk, and then it gives you the breakdown, looking at the breakdown in terms of cups of coffee relative to fetal death, and it gives you the relative risk and the 95% confidence interval for those estimates. And so you're supposed to interpret them and why you think that the author presented the information in this way. So identifying source of bias, and then to calculate the population attributable risk and interpret the results. And then you have this that you started with the rate ratio. That's it. So when you have spare time, when you're studying, that's in spare time. When you're studying, then you'll have them to do to concretize the concept. So that is EP 1. Let me just thank you all for your participation in EP 1. For the group from Biomedical Research, I think you should attend 2 lectures in EP 2 at least, which is a lecture on clinical trials and the screening lecture. There may be some minor changes in the schedule in terms of switching the dates with me and Dr. James. I think I'm doing screening on the 27th, I think, of November. And then whenever there is clinical trials, because for the study designs, that will conclude the study designs for you. So you can always join for those 2 sessions. And if you want to come and sit in for EP 2, you're always welcome. I know you'll be happy to come, and I'm not looking at you. But those 2 lectures, it would be nice for you to just conclude this EP portion by sitting in those 2. This is the last EP 1 class, so don't want anybody to tell me about time between now and exams.
So the revision session for EP 1?
The revision session is going to be the Wednesday before the exam. Because that is the time that they're going to take up on the book.
It's not that we don't want to take up records.
No, but I don't, you see, when you come to a revision session where you don't read anything, it's not beneficial. So I'll do it on the Wednesday. And remember, you have an exam on Monday and Tuesday, so you'll be studying for research methods on environmental health for those who do those courses. So you will focus, you'll not really focus. You probably read some things before, but you're gonna say that you can finish reading Tuesday afternoon and Wednesday for your EP on Thursday. I know. You start reading now, but the real buckle down and yeah. So Wednesday you can get revision. Always a class party. 4 questions. 25 marks each with lots of stems. No choices. Brain joggers. That's it. 25%. All of 75. So that, you know, because I know that that is their place to shine, I give the bigger mark there. The exam. No. You guys are already halfway there. You can collect on Monday. This is a lot of printed. I'm not saying you know, because they're probably are really good at us. But you see when people write out and upload them, it's so hard to print them. So we just print everything. They never get no we weren't here today. What I did, I also can't believe it. I think if everybody submitted a Word document, sometimes it's not so bad. Sometimes it's not bad. Huh?
You like Word documents?
It depends on how you do it. In terms of marking, sometimes I'm kind of, you know, putting in track changes and comments, but another time, I think it's just mark on paper.
For written update.
I don't want anybody's written assignments. If you don't have to write the one, because sometimes your handwriting is so bad, it's hard to. In COVID, I really enjoyed the fact that people actually type and do all their assessments. I only agree with it, but I must say that some people actually wrote on paper and took a picture of us. And then the thing had size issues because you know you take the high definition photos with your phones and then you can't upload the 6 pages because it's high quality on your expensive phones. Huh?
But they want to make sure it's clear, straight.
Correct, but and then you submit and we don't get all the information. Hey guys, that's it for EP. Samantha had a question? Samantha, I see you down there. You online too?
I know it's a different
Oh.
Samantha. I'm not sure if it was mentioned before or in the previous class, but I was just checking to see if the brain joggers, if they were already graded.
Most people.
Okay,
You can ask Miss Prince. The reason, so I left most of them at home, which is why I'm saying Monday because I'm not coming tomorrow.
okay,
So
so you'll
Monday,
be what
just
time Monday?
tell us the email Miss Prince and you can get it. Or come for your paper.
Okay,
Whichever.
all right, thank you.
That's it, Samantha?
Yes, that's
So
it,
like you
thank
had another
you.
question.
Oh no,
Okay.
that's it.
the MCQs for research.
I don't know that anybody needs to go through it, but if you want, then we can go through it before.
Treat them.
Hmm. We can go through it before then. All right, guys, are we in the mood to present our primary health care? Yes, you will get a break. I was just talking about taking a break and coming back. Huh? So what break time you mean? 30 minutes? 5, okay, so 5 minutes. Guys, so
But then, because it's not just the presentation, the presentation is that you're.
no, I mean, no, I'm not teaching anything. It's really just providing a summary of what you all said. That, you mean the case study? Like Effie? Let me
Not but I get.
tell me what's your fee.
I'll be back.
All right, so what time? 7 o'clock? So we can leave early. I just really want to hear about it. It's really just to share. That's all. Alright, so this is give download. You send it? Or you want Kay to come? You ready, Kay?
It was, see if it come up now.
Okay, one of my comments.
Or not, camera.
Okay, all right, guys, we're gonna start with the presentations. We're gonna start by presenting improving the health of the poor in Mexico. And then we'll go back to group one.
Oh, you know what I think happened? They said that they had made my own go into spam, my name.
All right, we're not finished, you come.
Hi, good evening, everybody. So our case study was entitled Improving the Health of the Poor in Mexico. And the group members are Cindy Pierre Charles, Kay Palmer Cole, Janine Morris, and Alia Ratchery. So summary of the problem. The poor in rural Mexico had a high infant mortality, poor reproductive outcome, and high incidence of preventable childhood and adult illness. And this is as a result of unhygienic living conditions, poor nutrition, and social deprivation. So 40 to 50%, which is about 103 million people, live below the poverty line in Mexico, in rural Mexico. And 15 to 20% is classified as indigent. 3/4 of all rural families.
Okay, if you remember.
No, I don't know details. So 3/4 of all rural families fall below the poverty line. And the villages, they have no paved roads, sanitation, or water. And only work available is as an agricultural laborer. The indigenous people speak little or no Spanish. And this, of course, leads to them not being able to participate in certain programs or essentially. So they are basically disenfranchised. And of course, there's a high dependency on family that is in the US. That is how they would get their funds. Half of students drop out after grade 6, 42% drop out after grade 9, and there is low use of health services. It's about 0.65 visits per year per person. There's protein energy malnutrition, which is widespread, and there's stunting occurring about 44% of 12 to 36-month children. There's increased mortality and childhood illnesses, and this is thought to be linked to sanitation. So my other group members are going to continue the presentation. They're online.
Good afternoon, everyone. So an intervention program was started, which was called the Progressive, which focused on 3 main links: education, health, and nutrition. So cash transfers was provided to families to improve the use of preventative and other basic health services, nutrition counseling and supplementary foods, and to increase school enrollment and attendance. So as I mentioned about the 3 links, cash was given based on specific criteria. So for education, cash was given only if each child under 18 years old were enrolled in school between the 3rd grade of primary school and the 3rd level of secondary school. The criteria for health, cash was given only if each member of the family accepted preventative health services, and the criteria for nutrition was cash was given only if children aged 5 and under and breastfeeding mothers attended nutrition monitoring clinic. There's a co-responsibility between the citizens and the government. So the government provided cash transfers to poor households only if citizens take children to clinic and schools. Mothers were the ones that were given the the monetary benefits, as studies shows that they are more likely to spend it on the children's health and welfare as where the men will spend it on other things. So no penalizing was done if the household members eventually got a job. The household would be assessed after 3 years.
And the enabling factors for success. There was ongoing monitoring of school attendance and clinic visits. There was external monitoring so that if there was a change in the government, it wouldn't affect the actual program itself. Indicators were scrutinized at all levels. There was a cap on the funds transferred to families per month of $70. And each household was allowed to stay in the program for 3 years. And after that, there was a reassessment done. In terms of the selection criteria, it was done based on geographical location, household, and there was also a community meeting held. And this was to determine if the households selected were eligible and if anyone was missing. And citizens felt empowered because they were a part of the planning process. The barrier challenges that were encountered were social division, in that all persons in poor communities saw themselves as being poor. So the persons that were not selected for the program from these communities were obviously not pleased, and this led to some social division. Also, the program was a large-scale program, which costed about 700 million per year by 1999 and 1 billion by 2000, which was 0.2% of GDP. And it was difficult to do cost effectiveness analysis. The program results and lessons learned. So the program covered greater than 4 million families and represents close to 50% of Mexico's annual anti-poverty budget. What was seen was that there was a significant improvement in health, education, and nutrition. In terms of education, 11 to 14%, there was an 11 to 14% increase in secondary school enrollment for girls and a 5 to 8% increase for boys. A 20% increase in transitions to high school and a decrease in child labor was also seen. In terms of nutrition, children under 5 years old sought well childcare and nutrition support, as well as 12% of lower incidence of illness was seen than in children not in the program. Adults had 19% fewer days of difficulty due to illness. There was also expansion of the program to urban areas. There was a youth with opportunities saving plan component in high school for children. There was funding available in the form of loans. And this inspired other nations as well to take on a similar model. These other nations included Argentina, Bangladesh, Nicaragua, Honduras, Colombia, and other countries. And yes, that was the conclusion of our
case study. What were the key takeaways in terms of what do you think enables the program?
A part of that was involving the community. So they felt like they were a part of it. They were able to determine which members in their community they thought were poor and needed the program. So that was good. And so the incentive, so the mothers had to take the children to the clinics and to school in order to get that $70 per month, or close to $70 per month. And I just think they felt empowered in the end. You know, the children are getting better and they were getting money and they felt like they were part of the program.
Did it come out because the healthcare in Mexico was not at a charge, right? They didn't have access problems?
No.
But when they gave them the money, they went?
They went.
All right.
Wait, Dr. Thompson, what would I had a problem hearing the questions. Could
Yeah,
I was
you
asking
yeah, it was
what
very
were
low.
the key enabling factors in terms of, so a big one was community participation. There are other things that came out. Which, I mean, we don't have, I have them, so we can talk about them at the end, but a big part of this piece was the community participation.
Okay, all
Which
right.
was fine.
Okay, thank you, Dr. Thompson.
Thank you. Who's coming next? Anybody have any questions about this case? Who knows about the PATH program in Jamaica? Is it a similar thing? Huh? To an extent, what's different?
Entry point. The criteria to enter on paper seems pretty straightforward. Although when it does come on to individuals accessing the same, it's a bit difficult. As the people who are in charge of admitting the individuals, they're not always consistent in how they, the criteria that they use to admit individuals. So, for lack of a better term, it's a friend thing. So, what
You think so?
I do think so, because growing up in an inner city, I've seen it, where individuals who would have ticked all the boxes, however, they are not quote unquote destitute, or they're not
Let me have pick latrine.
yes, right. So basic amenities are seen as privileges.
So
Right?
the
In the
inspector,
20
if you have a television, they're not.
you're not getting it. If you have a fridge that is not from 1902, you're not getting it. If you have a gas stove.
So people go around the system and tell lies.
So, right, so how the system ends up now, they don't give their true addresses. They find a space that is deemed to be less than. They occupy it because inspector will come and they present it so that, okay, I'm less than, so I can get the money, right? And then, so that's how it goes. And then now there's also, I don't believe we use the PATH program to its extent that it should go, because a lot of people don't think about PATH at the primary level. When it comes down to the secondary level and even tertiary, a lot of people don't know about the grants that are available to PATH students to further education.
And in Jamaica, I find that a lot of parents, the children will not go to school, and you won't get the path, they don't go. So attendance is still poor.
But you don't get the cash transfer if you don't meet the requirements. Is it that here they're not monitoring enough to know that
It's
people?
not adequate monitoring. So some places there.
So no,
on the
some
team.
are taking off it, and then we say to them, you need to send the child to school and go back and speak to them so you can get back on it, and they're just drag it. And one person was like,
But the conditions are similar though, in terms of, they will say you need to go, you need to get your vaccines, you need to go for your visit, you need to go to school, and attendance becomes a requirement. And it is hoped that, because what this case showed, and it is a similar case as here, as healthcare is available, accessible to them, but they still don't go. So, but when they get the money, they actually go because they know that it is, right. Right, so they use that.
And we ran through the 0.2% of their GDP, what is that?
It's a lot though. It was a lot of money, by the way. It was a lot of money, but 0.2% of the GDP. Go ahead.
All right, good evening, everyone. All right, so our case is based on controlling tuberculosis in China, and presenters will include Makisha Archer, Marcia Cameron Dawkins, Wasimi Blake, Sunil Danai, and myself, Simone Doctor. All right, so just to give you a breakdown of what we'll be looking at today is a summary of the problem, key actions taken, enabling factors for success, barriers or challenges encountered, and the program results and the lessons learned. So for a problem summary, in the early 1990s, TB was a major public health crisis in China, with 1.4 million active cases and 360,000 deaths annually. The existing national TB program was ineffective. Now, a major initiative was undertaken in 1991, and it was called the Infectious and Endemic Disease Control Project. Now, actions included the use of the Directly Observed Treatment Short Course, also known as DOTS program, and the use of international support systems. Enabling factors included heightened political will amid collaboration with World Bank and the WHO for additional funding. And barriers and challenges included coverage of nearly all 13 provinces, including the rural areas, and the sustenance of funding for the program. Now, amazing results came from the program, and these included 95% cure rate for new cases and a 90% cure rate for recurring cases. It also resulted in the treatment of over 1.5 million cases, resulting in the elimination of over 836,000 cases of the disease. Among lessons learned was how effective the DOTS program was in curbing TB cases and the importance of international collaboration in the success of any program.
So what were the key actions taken? So as we said, in 1991, they launched this program, and the most effective part was the adoption of the DOTS strategy. So why this was important? The program was delivered through a network of local TB county dispensers. So what they did is they trained healthcare workers and even some community persons to just directly watch the people take their medication, because they found that that was the major fallback. Is a situation for tuberculosis where you need to take 6 months of medication. If you default before the 6 months, they were developing very high multi-drug resistance. So we needed them to be incentivized to ensure they take the full 6 months and be completed. And one of the reasons that they couldn't take the full 6 months is that the medication was too expensive for the Chinese. So they had a system where prior to this initiative, they had to pay out of pocket. But with this initiative, they created the dispensaries where they gave them the drugs free. Then the trained health workers, even the doctors in the communities, they gave them extra money just to look after these TB patients and to make sure they get the refills of their medication and that they took it. So as I was saying, it was very detailed information on each patient and watching them take the medication to ensure accountability. And they were able to accomplish this by also securing international support from the World Bank and the World Health Organization. And they didn't only provide money, but they really helped them with the technical expertise and maintaining legitimacy and auditing of the whole process. So our next group member will come in for the factors for success.
Okay, factors for success. So DOTS was a factor for success. DOTS was a factor for success in controlling TB. Elements of DOTS that were included that contributed to the success of the program, as was previously mentioned, a regular uninterrupted supply of all essential anti-TB drugs was available, and patients were observed for between 3 to 7 days per week, self-administering the antibiotics, and a standardized recording and reporting system that allowed assessments of treatment results for each patient and of the TB control program as a whole. So government support was another factor. As was mentioned, the Chinese government formed the National Tuberculosis Control Programs to monitor DOTS implementation. The first iteration began in 1981, and then it followed with the IEDC project, which was founded in 1991. International backing through WHO and the World Bank had also been received. $58 million was received from the World Bank in 1991, and that had been used to fund the IEDC project. So affordability was another factor. DOTS had been ranked as one of the most cost-effective of all health interventions. In some countries, the drugs used in DOTS cost as little as $16 per patient for a 6-month supply. In China, diagnosis and treatment was government funded, an important feature of the program because fewer than 20% of the patients had health insurance. Next, community involvement. So as was mentioned, they had involved village doctors with basic health training, and they were financially compensated by the government for patients enrolled, throat swabs done at follow-up, and for each patient who completed the treatment. So structured research on implementation was done throughout the project. So pilot programs of separate strategies were conducted first before expansion to other TB affected provinces. Specialized TB clinics were created to manage symptomatic patients. A National Tuberculosis Project Office and a Tuberculosis Control Center were established. Operational research on management, economic, social, and epidemiological factors was encouraged to improve TB control and establish a basis for future health programs.
Continuing with barriers and challenges.
Okay, so the barriers and challenges are as follows. The main challenge or barrier was financial. There was inadequate financial support and this hampered the programs. The human resources and technical capacity, particularly in poorer provinces with the weakest primary healthcare infrastructure. And these technical capacity includes the ability to diagnose disease accurately, manage data, conduct laboratory testing, implement treatment protocols, monitor program outcomes using appropriate tools and expertise. And this results in negative outcome and widespread of the disease. Another barrier was the whole problem of widespread disease burden. As recorded, 400 million persons were infected with TB, making it the leading cause of death, and 1.4 million developing the active disease each year. And this is due to the widespread of the TB and ineffective treatment regime. Now, this was compounded by the multi-drug resistant TB, which led to incomplete or irregular treatment and poor compliance. There was also the problem of co-infection with HIV, which complicates the diagnosis of TB and subsequently the treatment. There was also in terms of the health facility, there were limited healthcare infrastructure, whereas there was the whole and ineffective programs resulting in deficient networking of diagnostic laboratories and inadequate system of reporting and evaluating cases. Then there was also the socioeconomic problem, as the cost associated with treatment of TB was a major challenge, not only for the government, but also for the people affected. Now, treatment offered in urban hospitals were too expensive, resulting in patients abstaining and or abandoning treatment early. Now, getting patients, especially in remote areas, to consistently visit dispensaries for directly observed therapy requires significant effort and resources, and that put strain on cost and their finances.
Okay, so for results and lessons learned, China's strategy proved to be particularly effective, surpassing the global target of curing 85% of identified patients and achieving an overall cure rate of 95% for new cases, with approximately 2/3 of the overall success occurred within the first 2 years of the program's implementation. China also achieved exceptional cure rate for relapsed and retreatment cases, reaching approximately 90% for these patients. noting a marked reduction in multi-drug resistant tuberculosis in province covered by the DAT strategy, but about 3 times lower than those in provinces without DAT. Over the 10-year period, the number of TB cases in DATS covered areas declined by 36.1%, averaging about 4.1% per year, compared to a slight decline of only 3.1% in non-DATS areas. Since the introduction of the DATS program in China, more than 1.5 million patients have been treated, preventing approximately 30,000 TB-related deaths each year. By the end of the program, DATS coverage had expanded to reach 96% of the population, achieving a national treatment success rate of 94%. In a national TB survey conducted in 2000, it was estimated that the program eliminated 836,000 cases of pulmonary TB, as mentioned before, 382,000 cases of cultured positive disease, and 280,000 cases of smeared positive diseases. For the lesson learned, China's 10-year IEDC program demonstrated how collaboration, adequate funding, strong political commitment, effective governance, and sound technical approaches can lead to a remarkable reduction in TB prevalence over a relatively short period. The success of this program provides a model for other countries, particularly those with low socioeconomic status, to implement large-scale interventions for communal disease control. The program also showed the importance of an effective triage or screening system accompanied by proper documentation and case tracking, consistently quarterly and periodic reports summarizing case findings and treatment outcomes from field levels to administrative officers proved extremely useful for monitoring and evaluating program performance. Political commitment at various levels of government played a central role in the program's success, ensuring consistent supervision, management, and maintaining the program's effectiveness and longevity. Careful attention to administrative, managerial, and financial controls can contribute significantly to the overall success of large-scale interventions. The DAT program demonstrated that rapid scale-up could be achieved while maintaining high coverage and cure rates. China's experience further illustrated that it is possible to improve cure rates and reduce treatment failures on a large scale without compromising treatment quality or case management. With China's having the highest status of MDR-TB cases in the world, approximately 30%, the success of the IEDC program is in reducing MDR-TB cases provides hope to the rest of the world. The use of incentive for both patients and healthcare providers proved to be highly effective, providing free diagnosis and treatment for TB patients, along with monetary incentive for care providers, significantly improved adherence and treatment completion rates. However, the program also revealed challenges associated with balancing incentives. Hospitals, which were not included in the incentive structure, were reluctant to refer patients to the TB dispensers, preferring to retain them for paid treatment. This led to higher patient dropouts and incomplete treatment courses. The lesson learned from this program should be adopted globally with urgency, as TB remains one of the leading causes of death and disability worldwide, with nearly 1/3 of the global population still infected. We thank you. Okay.
Next 4 point method is additives. It's already loaded, so just escape that and present.
All right, so good night, everyone. My group got Eliminating Polio in Latin America and the Caribbean Presenters will be Janelle Jones and myself. Melissa, Corel, and Bonita, unfortunately, are not in a position to present. Right, so the summary of the problem. So poliomyelitis, polio, is a viral disease that attacks the nervous system, causing paralysis or subsequently death. Incubation period 4 to 35 days, 90% of infected individuals show no symptoms. In the late 1900s, there were 15,000 paralysis cases and 1,750 cases per year in Latin America. An important watershed moment in 1952, the inactivated polio vaccine, IPV, was developed in the United States, secondary to a very famous individual from the US contracting polio, and that then propagated a Mickle Foundation, Dimes and Mickle Foundation, that resulted in the funding for the vaccine. Subsequent to that, the oral polio vaccine was introduced in 1961. In 1977, the OPV was integrated into the national immunization programs. And in 1985, PAHO launched the Regional Polio Eradication Initiative. All right, so our key give me one quick second. I don't have any of my notes, but that's fine. So the key actions that were taken, right? There was interagency global coordination from PAHO, UNICEF, USAID, the International Development Bank, Rotary International collaborated through the ICC, right? So the National Immunization Days, NIDS, was a twice yearly campaign that allowed for immunization of all children under 5, right? Operation Mop Up, the door-to-door vaccination in high risk and low coverage communities, surveillance systems, broadening the reporting sites and having a larger reach of diagnostic labs for stool testing, an incentivized program where there was $100 reward for suspected cases, and training and upskilling. So thousands were trained in cold chain management, surveillance, and data reporting to optimize the response to the polio epidemic. Right, so there were a few enabling factors for success. One of these being strong international and regional collaboration, right? There was also high political commitment and financial investment in the program in the Latin Americas. And then there was active community participation and volunteer support, right? And what made the program so successful, one of the major contributing factors, was the affordable and easy to administer oral vaccine that was given in 3 doses, equally spaced, right? And then there was the creation of a comprehensive surveillance system for polio that was subsequently used for other diseases that were present in the Americas. And a key point, once the region noticed that the program was successful, it was broadened, and then it was further integrated into the immunization schedule, where there were 5 other vaccines given to time immunization for the child under 5 years. And that was then brought into the broader maternal and child health services. I'll now be turning over to Ms. Jones.
Okay, so now we're at barriers and challenges. The campaign faced several challenges. In some countries, they had weak health infrastructure, which was an issue when it came onto vaccine storage and making the vaccine delivery very difficult. Secondly, they had financial constraints and dependency on outside donors, which created some form of instability and threatened the long-term sustainability. Third, remote and hard-to-reach communities poses logistical challenges, resulting in delay in coverage. And then we had heavy migration leading to unvaccinated populations, which is just basically people just moving across the borders. Delays in lab confirmation of case. It took approximately 10 weeks to get the results back, and that posed an issue if the person was actually confirmed to have polio, because he would have probably spread it somewhere else. Finally, vaccine-derived outbreaks, such as one in Haiti and DR, it just kind of highlights the ongoing risk there is. Program results. The last indigenous case of polio in the region was identified in 1991 in Peru. By 1994, the Americas were officially certified polio-free. Immunization coverage exceeded 85% for all EPI vaccines. And the cost of the campaign was approximately $120 million US, and saving treatment cost is approximately $217 million in 5 years. So strengthening health systems, expanded lab networks, and improve national capacity, which therefore increased the surveillance capacity, and it's also inspired the Global Polio Eradication Initiative, which was established in 1988. Okay, lesson learned. Well, firstly, that sustained political and community engagement is essential for eradication. Second, regional coordination is required to promote accountability and consistency. And then the third, initiatives help improve case reporting and compliance. The integration of surveillance strengthens the border's health system, and funding, Fourth, integrated surveillance strengthens wider public health capacity. Fifth, continued vigilance and steady funding are critical to prevent resurgence. And final, this model shows that similar strategies can be applied to other infectious diseases. The success of this campaign made the Americas a global example of disease eradication. It inspired global efforts, leading to over 2 billion children being immunized against polio worldwide. This experience demonstrated that disease eradication is achievable through solidarity, strong governance, and coordination. It also built public confidence in health systems and fostered long-term international cooperation. That's it.
Go next.
I don't have a PowerPoint, you know.
Okay.
Is it PowerPoint it was having?
No.
Okay.
Okay.
Okay, thank you. Good evening, all. So my group's topic is preventing dental caries in Jamaica. Group members, myself, Oshina Snape, Cheryl Smith, Daniel Walters, Krishna Wallace, and Shelley Ann Thompson. So the summary of our problem. Dental caries is a progressive loss of tooth mineral and invasion of the demineralized tooth by bacteria.
Oshina, can you share? Sorry, Oshina, can you share for us, please?
I'm sorry, I don't have a PowerPoint. I'm
Oh,
reading
you're
from the
speaking
Google
from your
Docs.
head. Okay, lovely.
You want to share the document?
I mean, sure, why not?
No, I didn't hear that. It's okay. Go ahead. Sorry.
Do you guys need visual aid or no?
Something for visual.
Okay, I'll share it.
Please and thank you.
You're welcome.
Somebody else wants to go while Oshina finds her shares.
I sent it to Sebastian already.
The Firefox.
Yeah.
Go ahead.
I could just share it from my laptop. Like, that's an option.
And share.
Oh,
We have
that-
it.
It's the same document, it's fine.
Cool.
So should go back to Zoom.
Guys, please don't edit.
Go back to Zoom.
Oh, Zoom?
Yes.
I don't know, my glasses not here, see? I think it's down here. It's down here, sir?
Yeah, what's your problem? Just a minute.
Thank you so much. So summary of the problem, dental caries is a progressive loss of tooth mineral and invasion of the demineralized tooth by bacteria. It develops when the bacteria from sugars stick to the surface of the tooth, forming a plaque by the bacteria as a byproduct. It posed a major health problem in Jamaica in the early 1980s, with children having 6.7 decade missing or filled teeth on average. It was also noted that fewer than 3% of children were free of caries. Not only does dental caries affect children, ranging from dietary constraints to self-image and esteem, it also affects adults, whereas pregnant women with periodontal disease are 7 times more likely to deliver a preterm or low birth weight baby. Access to dental care and oral health education was limited. So key actions taken. Introduction to the salt fluoridation, salt rather than water, initiated by Dr. Warfare. I think, okay. Introduction of the salt fluoride, what's going on my tongue today? Fluoride. I said it first, good the first time. Salt fluoridation. Salt rather than water, initiated by Dr. Warfare. I said it properly, Warfare. A trained dentist partnering with the Alkali Limited, the salt producer, they began to create fluoridated salt. Partnership with PAHO, the engineer Milner from the salt producer and other engineers went to Switzerland. What's going on with me today? Switzerland to learn about salt fluoride. Jesus. What's going on with me today? They bought the necessary equipments to fluoridate salt.
It can come out of the documents.
Daniel, I corrected it.
Go ahead.
The Ministry of Health and the Jamaican Parliament complemented the necessary legal and regulatory framework for salt fluoridation. In 1987, there was a major advertising campaign to inform Jamaicans about the fluoridation of salt, and the fluoridated salt went on sale. The Ministry of Health provided biological and chemical monitoring of salt. Alkali salts producers did the monitoring daily. The Jamaican Bureau of Standards monitored the fluoride concentration of salt. Why this is okay. Enabling factors for success. The support from PAHO provided guidance and expertise to ensure effective and best practices. Just having a single salt manufacturer in the country allowed for uniformity and easy coordination of action. Because the island had low levels of natural fluoride, salt fluoridation was deemed safe and effective. Having a receptive engineer in Alkali Limited and the necessary equipment was relatively inexpensive. Due to the lack of research on impact of fluoridated toothpaste, created an opportunity for encouraging more research so that an intervention can more clearly be judged on its effectiveness. Barriers or challenges encountered initially The oral health program lacked financial and political support because in comparison to other health programs, public health programs, it was seen as severe or life-threatening. Dental treatment was expensive, and the cost, still is, and the cost of treating dental caries increases with the progression of the condition. In many developing countries like Jamaica, treatment was unavailable because of the shortage of dentists. So program results, there was a significant reduction of caries, and the index of severity had fallen by over 80 in 6 and 12 years olds. Even though people continue to consume large amounts of sugar, the prevalence of caries has fallen tremendously. There was a minimal risk, as only less than 1% of children showed any evidence of excess fluoride exposure, and in these cases, they were mild. Return on investment in salt fluoridation, for every $1 US invested, approximately $250 USD was saved for the future of dental treatment cost. Lessons learned. The need for community education for the success of any initiative gaining public acceptance and trust is critical for the successful execution. Collaboration of NGOs and government can have positive and lasting outcomes on the health of a nation, as evidenced by the 80% reduction in dental caries for the addition of fluoride to salt. And that is the end.
Sorry, just wanted to kind of highlight one thing.
Elaborate.
Yeah, so when it came around to the enabling factors for success, I was a little bit conflicted with respect to putting it in enabling factors for success versus in the lessons learned. So from the case, we learned that there was a lack of research with respect to the impact of fluoridated toothpaste, which would have predated the outcomes of the research in terms of checking the kids back in to see how many caries it is that they had. So it was based on that absence of research that they said that it was likely due to the fluoridated salt, why it is that they saw a sharp fall off in the amount of caries in that target group. So to then say that, to then judge the initiative as a success, that's why it is described as kind of like a matter of narrative, because since we can't say that it wasn't that, then it lends more argument or more credence to say that it likely was our intervention. But that also presented itself as a lesson or a lesson learned, wherein that if it is that you are more aggressive in terms of researching, as opposed to just kind of hoping that it's just somebody's area of interest, then that can further strengthen your arguments when it is that you are to petition government to make particular interventions in the population. So, yeah.
Yeah, thank you, Daniel. I think we'll see that coming out in another case as well. The importance of using the data to strengthen whatever argument you're making.
All right. Thank you, Sheena.
All right, so the group presenting curbing tobacco use in Poland.
We're gonna share our slide. Give us 2 seconds.
Just a second, trying to, can you guys see the screen?
No, not yet.
There. All right, let me start over. Just a moment, please.
Okay, perfect. All right, so good evening, everyone. This is Group 1, and we'll be presenting on curbing tobacco use in Poland. Group members are listed as follows: Melissa Forbes Gabidon, Shalisa Gaynor, myself, Vanessa Green, Alicia Hamilton, and Veronica Hamilton. So the objectives, just like the other groups: summary of the problem, key actions taken, and so forth. It's okay, you can go ahead. All right. So in terms of the problem, so globally, tobacco is the second deadliest threat to adult health in the world. And this picture depicts that 1 in every 10 adults will die from the effects of tobacco. And in today's world, it is estimated that over 500 million people will die prematurely because of tobacco consumption. Next slide, please. Right, so we recognize that globally smoking is on the rise, especially in developing countries. More than 75% or 3/4 of the 1.2 billion smokers worldwide actually live in low and middle income countries. I don't know where they get money from, but they're the ones who are smoking the most. And current smoking trends says that 1 billion people will be killed in the 21st century if we continue to smoke. And the deaths related to smoking is expected to double by 2030. And cancer is the most common disease caused by smoking, and it's responsible for half of the cancer-related deaths, as well as smoking is attributable to other diseases like cardiovascular disease, such as heart attacks, CVAs, strokes, and respiratory diseases such as emphysema. So as it relates to Poland, right, back in the 1980s, it had the highest rate of smoking in the entire world. And in the 1970s, the average Polish person or the average Pole smoked more than 3,500 cigarettes for the year. That's 175 packs. Remembering that 20 comes in a pack for the year, one average Polish person. Next slide. Right, so also the middle-aged Polish man had one of the highest rates of lung cancer in the entire world as well because of their smoking habits.
Vanessa?
I'm muted, sorry guys. Passive smoking also affects vulnerable populations such as children, pregnant women, the elderly, and the economic burden on individuals, families, and societies due to premature death and disability, was high because of smoking. And the poor are more likely to smoke than the rich, as we were seeing in the developing countries, due to disparity based on educational level as well. Okay.
All right, good evening, everyone. I'm just gonna speak on the key actions taken. So in 1995, the tobacco control legislation was passed in Poland, and this really looked at where health warnings were placed on the cigarette packs. They also included a tobacco tax, which served as sort of a deterrent in terms of increasing the economic burden to buying cigarettes. Smoking was banned in health centers, schools, and enclosed public workspaces. There was also a ban on the electronic media advertising of smoking products or cigarettes. There was a ban on tobacco sales to minors, and this particular part of the legislation was actually put in place to decrease the onset of smoking in Poland, because what they found was that Polish young men by the age of 15 years had a significant smoking burden. And so they also had a decreased life expectancy in comparison to their peers in Europe. They also included in the legislation free treatment for smoking dependence, and this was pertaining to the nicotine addiction that would have been associated with smoking. And then you also had health education and promotion campaign that was done by various members of the health sectors, NGO, and civil society, such as the Great Polish Smoke Out. This is just a photograph showing the various packaging and how they would, try to put information on the various packaging for cigarette to deter use. I'm passing on to the next person.
Good evening, everyone. So as it relates to the enabling factors for success, Poland's scientific community really laid the groundwork for their anti-tobacco movement by increasing the awareness of the health impact of smoking. And this was done via health research in their own country. So basically, they did multiple projects that highlighted the particular link between the negative effects of smoking and, of course, their escalating cancer outbreak at that time. And this scientific research actually attracted a lot of international attention. So they held a series of international workshops as well as scientific conferences. And this attracted international groups such as the World Health Organization, who partnered with the Polish Anti-Tobacco Society to help drive awareness of the dangers of smoking. And of course, as time progressed, this also attracted political attention, and they were able to get political commitment to counter the significant economic influence of the tobacco industry. So with the political community supporting them, next slide, please. So with the support of the political commitment, they were able to get supportive tobacco control legislation, which was also instrumental in driving a lot of the anti-tobacco behavior change, as well as effective communication strategies to further influence that behavior change was also achieved through a health promotion foundation that was established. And of course, access of the free media was also covering significant health issues, and they also help to shape public opinion about the tobacco control legislation. So they've actually viewed that as like a David versus Goliath fight in terms of the Polish advocates versus the tobacco companies rather. Moving on to the next speaker.
All right, so the barriers and challenges would include quitting smoking requires behavior change, which is not easily accomplished. And we saw where when they did the research and they could pinpoint the effect to it that affected the behavior change as well. So when individuals recognize that based on the research, the tobacco smoking is linked to it, then that's all. If they don't have the research to provide, then behavior change is not easily accomplished. So that was a barrier as well. Because most of the income, the economic benefits were from the cigarette industry, it was very hard at first because the government didn't want to buy in, considering that the industry stakeholders were investing over $11 billion into the economy. So that was one of the barriers as well. Next slide, please. Anti-smoking policies and tobacco legislations require strong political and civil buy-in to establish and to be enforced. One of the barriers initially was that there was not a lot of political buy-in based on what the article presented. The tobacco industry leaders have strong political influences and actively work to counteract anti-smoking and anti-tobacco measures. Many consumers are from low to middle income countries, and they were unaware of the impacts, which also highlights the importance of research. So the research basically highlighted the impacts, and once they became more aware, that barrier was somewhat removed. Next slide, please. All right, so program results and lessons learned. Cigarette consumption was reduced by 10% between 1990 and 1998. There was also a reduction in the overall mortality rate in Poland, as well as in the infant mortality rate and low birth weight among babies from 8 to 6%. Lung cancer rates were also reduced by 30% in a decade and by 19% among men 45 to 64 years. Prior to this intervention, lung cancer rates were similar in Poland and Hungary. Post-intervention, lung cancer rates reduced by 33% in Poland. And when compared to Hungary, which did not have any such intervention, it was increasing. So you see where in Poland, where they had the intervention, it was decreasing. When compared to Hungary, which did not have the intervention, it was not. It was still increasing. Next slide, please. The program results and lessons are continued. The Framework Convention on Tobacco Control, it garnered worldwide adoption and recognition. The World Health Organization and its member states also adopted this as well. There was also an improvement in health, which would eventually reduce the pressure on the healthcare system. One of the lessons learned is that behavioral change is possible when consistent effort use of inclusive awareness interventions and supportive mechanisms to create an environment conducive for successful behavioral change. Collaborative efforts with NGOs, civil society, health sector stakeholders, and politicians done correctly can produce positive gains in public health change. Next slide. Conclusion, this is a no smoking area.
Thank you.
Thank you very much. I will take the final group on the prevention of diarrheal diseases.
Good evening, Miss. Can you allow me to share my screen?
You're allowed. Nicole, you can go ahead, you know.
Good evening again. Is everyone able to hear me?
Yes.
Okay. So our case was preventing diarrheal deaths, and we looked at the case in Egypt. All right, so we're going to look at what summarize what the challenges were. In Egypt in 1977, some 50% of all infant deaths were due to diarrheal diseases that resulted in life-threatening dehydration. 1 in every 200 children who contracted diarrhea will die, and especially concerning dehydration. Annually, there are 2 million deaths from diarrheal disease in the developing world. The adequacy of the response at the time was intravenous treatment, and that was in question. As you can imagine, we know that that would be more expensive and the availability would be inadequate. So the key actions, before I go into the key actions, they actually did a pilot study in rural communities before they went into the major project. And they used the information that they garnered from the pilot to come up with these actions. They also had clear objectives of what they wanted to achieve, and that enabled them to be able to carry out all the actions that they had. So the first thing they wanted was to look at the product design, and from the pilot, they recognized that UNICEF at the time had 1 liter sachets for 1 liter, but most of the mothers did not have a container that was 1 liter, or did not know how to necessarily measure 1 liter. So what they did was to go with a 200 ml size, and they also provided the container, a branded container to mix the rehydration fluid in. And in addition to that, the mothers were introduced to the fact that the small soda bottle contained 200 ml. So if they didn't have the branded container that was provided, they could use those bottles to mix the salt in. In terms of branding, they actually, the words are in Arabic, so I wouldn't be able, but essentially it works out to the solution, that's what they called it, and it's a solution to treat dehydration rather than to treat diarrhea, because they recognize that the fluid does not actually cause the diarrhea to stop or lessen diarrhea. What it really did was treat dehydration, and the word they used was the word that was synonymous with drought to represent dehydration. In terms of the production, what they did was ensure that they had 3 months supply, and they also did forecasting, so they were able to track how much was in use to be able to say how much they would need in the future. In terms of distribution, they recognized that for smaller, more rural communities, what they did was have persons who acted as, let me find the exact word that they use. They use them as depot holders. And these are persons who in their own homes would store and then distribute to the villagers in the smaller. And they would either be distributed for free, or the price was like 2 cents to the persons. In terms of training, they did mass training. They were able to train 10,000 physicians, as well as they were able to train 14,000 nurses. And then in terms of promotion and marketing, they did a mass media campaign, and they used an actress that had a motherly appearance to represent the spokesperson, because they had found that they had used a male initially, but it didn't work out very well. Vanessa? All right. In terms of enabling factors, there was some information that they had from research that was done in Bangladesh that looked at, in this case, they actually taught the mothers how to make the solution. So they were able to use that. And then, of course, because they had done the community trials, they had information that could help them in terms of making it a broader program. And then they had just introduced televisions, so people were all excited about watching, and so they had a captive audience in terms of using the television as a medium for disseminating information. They actively involve mothers and physicians because they recognize very early that these were the people who you need to buy in for the program to be successful. The government actually owned the distributor, and it was actually cost effective. So when they looked at how much the benefits and how much cost savings and lives were saved, then it made sense. And then, of course, the monitoring and evaluation that was done along the way. And the major barrier was that the private sector was a problem. And the reason they were a problem is that you have antidiarrheal drugs, and therefore they could make more money from providing antidiarrheal drugs. The pharmacists would make money. The pharmaceutical companies would make money, and so private practitioners and private pharmacists were reluctant to join in. Williams Rayner will continue.
Good night again, everybody. So ultimately, the program was a rocking success, given all of those enabling factors and the way in which the intervention was designed and managed. Some specific results included increased production and distribution, fourfold, in fact, of oral rehydration salts, increased correct use of the salts and changing feeding behavior, increased awareness of ORS, and ultimately, and perhaps most importantly, a decline in mortality attributed to diarrhea. In point of fact, the data presented is that a reported 82% among infants and 62% among children was the reduction that was seen in Egypt between the years of note. So those are the results. Lessons learned, some lessons learned included that social and cultural contexts are key to any successful health campaign. And we saw that with the selection of the audiences. We saw that in terms of the sizing of the bottles that were used for the rehydration salts and so on. And therefore, ultimately, it is impatient of debate, the need for us in doing these types of interventions to onboard local prevailing realities. Monitoring, evaluation, and learning, MEL, again, a very necessary, critical part of any public health intervention, was used to very good effect in this effort. And again, ultimately fed into the results that we're seeing. And then from a marketing perspective, we see that there is some value in influencer marketing, you know, the use of the person who looked very motherly and so on for their campaign efforts, you know, with whom people could identify and listen to, and therefore felt inspired by in some way that then prompted them to move in the kind of direction that the organizers of the campaign would have wanted them to. Next one, Nicole. Right, Nicole?
Sorry, my laptop is having delayed reactions.
No problem. All right, so the final two lessons learned as we saw them was also the need for agility in executing a program like this. And of course, in the particular instance, that agility was informed by the monitoring, evaluation, and learning that took place in terms of the implementation of the program. One must, we found, be prepared to make adjustments during the implementation of such an intervention, while of course making space for the different stakeholders, in this case, the mummies, the doctors, and so on. And then finally, capacity building is an important element or piece of the puzzle, certainly for sustainability purposes. In this instance, health workers were trained to accurately diagnose diarrhea and dehydration. And of course, the mummies were trained in how to use the oral rehydration therapy. And again, that lent itself to the success that was seen with the project. And that's it for our presentation.
All right, thank you. And thank. You can stop sharing, Nicole. And Nicole, why you have so many tabs open? Just that's on the side.
It's a representation of all the work that I'm being asked to do.
You're really doing a lot. You're doing the most. All right, so here we had 6 cases, which I thought were 6 very interesting cases on things of varying nature. So we looked at prevention stuff, we looked at case management, service utilization. And what we've seen, what I realized, and hear me not, these people must be in health, you know. Some people mentioned the whole money piece. Some people didn't. I didn't bring it forward as much. But the whole cost effectiveness of whatever interventions. If you look at all these 6 cases, can you all see where we are with them now in our context? So if you look at what came out of, say, tobacco control, the Framework Convention for Tobacco Control, what came out of the diarrheal deaths is the whole oral rehydration salts. What came out of TB, the DOTS. What came out of the dental caries was the salt fluoridation. What came out of, what am I missing? Polio was the vaccines, you know, OPVs. And I'm missing the cash, and for the cash transfer, which is around healthcare utilization, that piece in terms of just ensuring that there's education, healthcare utilization, just simply based on giving people some money, because it's not like the healthcare is not there. And so as each group presented, there are some common themes that came up in terms of what's required to get some of these programs going. And some of the big ticket items that came up included what?
Political commitment.
My word. So trust me, so the whole thing of political commitment. And that piece is also very big, because what we saw in some of the cases that they had competing interests.
Yes,
So,
especially when they own the thing.
The tobacco. So when you have competing interests and you have things generate in terms of economic outputs coming from it, it's hard to now say take the high road for health, which is one of the struggles we have, because even with our local context where we want graphic health warnings, and the tobacco industry is saying, listen, because the tobacco industry really generates a lot of income for the country, for the health sector, you know, like it's not a small amount. But you see, we have to put the programs in place. So we get the resistance, we don't have the graphic health warnings. In terms of advertisement, which they should have a ban based on the Framework Convention on Tobacco Control. They find innovative ways of just trying to get the information to people. We also see where you have, you know, competing interests or those barriers relating to other people wanting to make a profit from the initiatives. We just saw it in the oral rehydration salt, where pharmaceuticals wanted to provide drugs to stop the diarrhea rather than addressing the rehydration part. And sometimes they also come with, if you think about like a Pedialyte compared to ORS, it tastes so good, you know, like, so you compete on certain things. So we're competing on taste, for example, even though it's far more expensive. Your child will want a better tasting fluid. And of course, you know, it looked just okay, you know, high rollout behavior. So you give them Pedialyte instead of the ORS. The ORS is not fancy. Oh, it's so nice, you know, like you drink it, it tastes nice and all of that. So,
And now they have
Lord,
the
this is
pups
not-
make it worse.
oh, whoa. and they're not cheap. Okay. All right. So political commitment was one thing we said. What other things jumped out in terms of cross-cutting themes that we saw? Community buy-in and community community involvement. And that community involvement took various forms. In terms of like development of a program, its execution and all of that. What else came out?
International funding.
Or I'm gonna put funding or financing of the program. And that came from dedicated funding from like government, but also donor funding to support whatever mission. What else came out?
Regional cooperation and also, I want to put it, looking beyond the region for basically what could be considered best practices.
So partnerships / collaborations, and this was with regard to whole heap of things, technical expertise, etc. And even for the funding piece. What else?
Training.
This was a big piece that came out, which was training, the whole thing of capacity development. What else?
Monitoring,
there was
evaluation, and learning.
Correct. Monitoring and evaluation piece was big. And another piece that is complementary to that.
Agility, so responding as you're monitoring and being able to change.
Yeah, but I'm looking for something specific, which came out in quite a bit at the presentation. Daniel spoke about it.
The need for research.
The need for research and just using that data to make a case, to make changes to the program, for example.
Right.
So the whole, yeah. But yes, Nicole, I will agree with you that the whole agility, because what you realize is that you may start with the implementation of something and then something come up and you have to change it. And so just being, I'm probably just gonna put it, this is not the word that I want, flexibility, but it's a little bit more than that, being able to adapt to whatever you come upon, which will go with this piece. Just making programmatic changes as needs be. The
I
one
think
piece
that's your word. I think your word is adaptability.
Adaptability. One thing that I wanted, and I'm not sure if we should put it with funding, I feel like it deserves its own place in terms of providing incentives. Because the incentive piece is a big piece in terms of people, in terms of the community involvement piece, the funding piece, the part, all of that. Just like when you incentivize people, they're motivated to do the action or to participate in the program. So I think it deserves its own space. And there are two other ones that I don't want us to forget. I mean, there are others, but
marketing and promotions and health education.
Yes, please. Yes, man. Marketing and promotion.
Health education.
Correct. So you see that those pieces, they were big because in all the things in terms of product placement, where you put the oral rehydration sauce, how you package it, how you tell people about it, similar for the tobacco piece, the salt piece, all of those things relied a lot on the promotion or the health education, health promotion pieces that will help to drive it. And so quite a bit of those things came together. Oh, the other, let's not forget the legislative piece. It's called legislative support. So for example, they had to change policies, laws, you know, things such as with the tobacco, for example. They had to do some legislative changes to support the implementation of whatever it is that they were doing. One beautiful thing, like a lot of these cases were quite a long time ago. And when you look at how sustainable those programs are now, you know, you have to admire them because, you know, it really took effort from people. They happen sometimes in just one country or one geographical area, but then now they spread to many places. And so it speaks to, you know, just how robust some of those things were. I mean, some of them were trial and error, but understanding the lessons learned and how you can implement it for sustainability purposes, really, we can really see them in what we do today. Of course, you know, there are challenges that came from all of this. We understood that people, you know, for example, don't know the sustainability of those finances also presented a problem. Resistance, because with anything, behavior change, any new thing, any innovations, we know that we're going to have some resistance, yeah? What is keeping up here? It's bedtime. Why are they not in their bed? Like it's 8:35, but like integration Thursday is at 3 o'clock and 4 o'clock. You know, so you have systematic issues, infrastructural issues, that may, yeah, logistics issues, competing interests that will really put will hinder just the effective implementation of your program. But regardless, you know, the important thing is, and there are many other successes that we've seen in primary. This was just like 6 cases of a series of 20. Because there are many other cases that, you know, people in primary healthcare that you look at, and, you know, there are really good cases that we can see that will transcend time, and they're still in place now. And of course, we're benefiting from 1, its implementation, 2, the lessons learned, and just that, you know, there's evidence to support whatever it is that they did to get these things going. And so it's just, for me, it's always just a light moment, and a lot of it is being achieved at low cost, especially now. Because what is it taking for us to, in terms of the vaccines, for example, the salt fluoridation, that's really low cost. The tobacco things, so it will cost us because we have to fight so hard because of competing interests. But really, they're low-hanging fruits, right? The oral hydration salts, low cost, big impact, all right? So that was the whole intent of that class, just to highlight some of those cases, to show that, you know, you can really get ahead, you can really have very good outcomes, and just investment that may not be so heavy, but it requires good coordination, it requires oversight, it requires lots of commitment, funding, and of course, you know, you have to do things in a strategic way when you're doing them. So, any final comments? Okay. So that's it for
for us. So thank you guys for your time. Thank you, teacher. I like that word, teacher. All right, so have a good one, guys. Good night.
All right, thanks, Doc. Later, everybody.
Night, everyone.
Bye.
Bye.
Whatever.
Good night.
God bless all.